All right, good morning, everybody. Thank you again for the invite from the HISP Asia group, and happy to be here talking about DHIS2 for logistics. My name is Brenno Horst, and I'm the LMIS tech lead at the HISP Center in University of Oslo. All right, so I have 45 minutes to get through actually quite a bit of content. I tend to get a bit excited and speak very quickly, so I'll try to be concise and to the point. And I'll go through a quick background. For this, I will be very brief, and you can have the slides, and there's a lot of content already on this background, and also links to additional information on what I'll be presenting there. And then I'll go through some slides on monthly stock reporting, which I think is the key here, the key message, and what I'll try to be conveying to everybody on what can be done with monthly stock reporting as a first step. Then transactional stock management, as Mohammed mentioned, so that's capturing real-time data, transactions at facilities. And then a tool for cold chain equipment management as well, all right? Those are three quick overviews, and then I hope to spend most of the time on a demo and analytics, where I'll show you where you can go in, both to our demo instance and going through the workflow for capturing data, and then some analytics that we've already configured to see what you can actually get out of DHIS2 for this logistics use case in a limited sense, in a specific sense, which is last mile, also mentioned by Mohammed. So I'll go through that, and I'll finish off with some implementation considerations, all right? So maybe first, how many of you here are working with or have responsibility for logistics or stock data, equipment data? I know there's already been mentioned. Anybody, just put a hand up if you have any kind of responsibility, engagement, interest in logistics and stock data. Okay, so quite a few of you. How many of you are very, very happy with your current system and current information system for logistics? Put your hand very high up. Okay, fewer hands. All right, so this is also very common, and what I'll try to then convey during the presentation is how you can leverage DHIS2 to meet very specific requirements, but also show some limitations where we then recommend an integration approach. So then I think it's a good segue to our background here, which is showing the HIS landscape. This is a World Bank 2022 report, which had this mapping showing the broader HIS landscape, the different needs and requirements, and how DHIS2 and other tools meet those needs. So along the top, you see health services, medicines and supplies, human resources. And then on the left, you see your different specific tools. Not exhaustive, of course, but you see how DHIS2 takes up a lot of space. And if you look at specifically LMIS in the green box, it's kind of split between DHIS2 and other tools. And this is a general characteristic of the landscape today. And what we then try to build on this and show is that with the existing DHIS2 infrastructure, with the investments, with the know-how, with the experience that countries have in implementing DHIS2, specific features can be used, can be leveraged to then capture stock data in an effective way. Of course, it doesn't help any individual country that it's been implemented this broadly, but in the specific countries where it's implemented, you have competence and know-how to be able to use it for the logistics use case. Also, as additional background, that we've been referring to specific documents that provide standards and guidance on logistics information systems. And the key one is the Target Software Standards, which was recently reviewed and updated by the Interagency Supply Chain Group, a group made up of Global Fund, Gavi, and many other partners, which really sets key guidance for these systems. So then on our website, we have a link to this document where we went through the specific capabilities that they're requiring for an information system. And then clearly identified, if you see on the right-hand column, and you can access this file and go through it and see DHIS2 capability, either that we meet the requirement and we have it in green, we partially meet the requirement in yellow, or we don't have that available and we put it in red, to be very specific of what we can or cannot deliver, or can deliver in an integrated implementation. So on the first line there, master product data. We're clearly saying we cannot function as a master product list or master product catalog, because the requirements for that at a national level for it to be used by multiple systems cannot be met within DHIS2, whereas for other specific cases, then it can be met, all right? So I think this is a very good first step to define what are your needs, what can DHIS2 deliver, partially or fully, and then to then set out on what can be implemented. Now, based on those requirements and based on the guidance, we have a very specific last mile solution focusing on health facilities and service delivery points, focusing on stock management, cold chain equipment management, and a few other things which I'll get into. And this is the last slide then on the background. Again, I'm going through quickly because I've already presented this before. We have a lot of content already backing up this information, but we look here at a very generic representation of a health structure. And on the left side for the logistics information that we focus on community health worker, hospitals and health centers, digitizing data and making use of data at that level. And then for central level, regional, and the supply chain and distribution down to the last mile, that we recommend using a dedicated ELMIS or ERP. And I'll get into the reasons for that. Also why we don't necessarily have the ELMS all the way down to the last mile, while leveraging DHIS2 is an advantage, all right? Now for monthly stock reporting, and you will hear me repeat this again and again. This is really a powerful way of digitizing facilities, getting data from the last mile into the supply chain to actually fix and improve stock availability, reducing stockouts, and actually providing some impact to the supply chain management. I think many of you are familiar with these tools here, stock cards and bin cards. This is the most commonly used tool at facilities to keep track of items. Either at the bin card level or a stock card, you have the quantities that are being received or issued, that's tracked on paper. And if done properly, which generally it is, we find that it is, can be very, very effective at the facility level. But when you're looking at a system level, you're looking hundreds or thousands of facilities, for this data to actually inform resupply, for this data to be useful at a higher level, it needs to be then shared and aggregated. And from the paper tools, it's very difficult to have that timely access to data, which is why we recommend strongly to have that then digitized within DHIS2 and for it to be made available for decision makers, either at the facility, at the district, all the way to central level, to quickly have your quantities for stock received, your stock distributed, stock on hand, stock corrections, to have that national visibility. Really a first step to digitizing facilities, which in large part are very much paper-based. I'll go through the analytics and show how very key indicators and decision-making can be done from this very simple data capture. All right? We've worked with a few different organizations and countries, and what we often see is that the quantity of data being collected, the disaggregation for any one of these fields and additional fields, often this list becomes quite large. The data set just continues expanding, and the burden of data capture for health workers increases. So then what I'll also try to highlight is how very key data can improve the stock replenishment and stock availability. So current stock on hand, and then the average demand. What is your average monthly consumption? With those two being key data points. And those are only 2 data points. We're not asking about disaggregation, about stock losses, expiries, how the stock was damaged. I mean, those are important data and they need to be reported on. But this is the actual key data that will inform the resupply and can actually improve the stock replenishment, fixing stockouts and not simply counting the number of stockouts. If I go back to the data set, we don't have stockout days here, which is a very common request. I know I'll get that answer or that question very quickly when we go into the Q&A. But we can add it and it can be reported on. But the key thing is how can this data inform the replenishment and actually reduce stockouts, not simply reporting on the number of stockouts. So fixing the issue at the root and not simply reporting on what those symptoms are. So I'll get back to the stock reporting. But now I'll go into the transactional stock management using Tracker. So this is a new tool that was released with version 40. So now this is using native DHIS2 features. It's not an additional app. It's entirely native, providing the ability to track every single transaction. It has a specific workflow for Android, so we're using Android only for this program. And there you see a screenshot of it, and I'll go through a quick demo in a bit. And it supports barcode scanning. And from version 41, so the latest version of DHIS2, you also have the offline analytics and the line list, so you can have a fully digital stock card. You can do away with your paper-based stock cards, your bin cards, and simply use the tracker to manage the transactions and then have a digital stock card. For that, we're also using the data exchange, what Jason showed yesterday and demoed, to then aggregate this data and have your monthly reports to meet your reporting requirements as well using this tool. Much more advanced. I will show how it's done in a quick demo. But again, first step, aggregate monthly reporting, and then where relevant, we then recommend to improve to this type of tool. Here you see the 3 different workflows that are currently supported. So it's distribution, which the vast majority of transactions are distribution, but also the ability to discard for any damaged or expired goods, but also make stock corrections if there's been any errors. So those are the 3 different workflows, easily identifiable with the color coding, which you're able to then conduct at a facility. Now the third then feature, which I'll demo these in a minute, is the cold chain equipment management, also using Tracker, fully native features, no need for any additional apps or additional requirements. Now this is a tool then used to manage and update cold chain equipment inventories. You can capture from the point of installation, logging alerts, and any type of maintenance that you conduct. You can track all of these, all the way to the end of life or decommissioning of the cold chain equipment. We've integrated it with the WHO PQS catalog to facilitate when you register a new unit, these attributes are already included. And we have specific intentions with this, and it's to provide informed decision making. So when you're distributing vaccines, you see the number of devices that are functional in a specific site, the storage capacity, and what you're actually able to see that the facilities have in terms of cold chain equipment. Strategic planning and purchasing, rehabilitation, replacing old equipment that you have overview within districts and even countrywide of the equipment available in that country. And to support, again, equipment inventories. Here's a quick just screenshot of logging alarms. So this is alarm counts in specific districts, and quickly you can identify where you have more or less performing equipment by district. And this same model can be used for biomedical equipment, so tracking, registering, tracking, and managing biomedical equipment in a hospital setting or really any other type of asset using the same tracker model. All right, so that was quickly going through a background, using DHIS2 at a last mile, registering and reporting on monthly stocks, the transactional stock management, and then the biomedical equipment management. So I'll quickly jump out of the presentation, and I'll show you where you can go to our website. And we both have a walkthrough on the website, so you can quickly do this without needing to download the Android app and having to connect to a server. You can navigate to DHIS2.org, to the logistics section here. And on the main page, you will have a lot of information, the background which I shared with you, but just down here, you'll see a walkthrough, show me how to use this use case, and a tutorial for the different workflows, all right? So here, you're in the shoes of a storekeeper or a pharmacist at your city's central hospital, and you're going to use DHIS2 to manage some stocks and cold chain equipment. You log into your Android app, and here you can keep an updated record of stocks and equipment. All right, so we're going to quickly go through the real-time stock management tutorial. I'll show you just part of it, and the other workflows you can actually do on your own. So I just choose the real-time stock management tool. And here you have a scenario which you can walk through. You start your day and you have your pediatrics department requesting you for some medicines and equipment. And this is the exact workflow on Android Capture. It's really just screenshots of what you would be doing on the device, all right? So once you open, you can navigate to the real-time stock management tool. You see there in green, and we open that. As I showed, there were three different workflows for distribution, discard, and correction. Distribution is by default selected. It's the most common transaction. Also, the facility where we're working is automatically chosen. And we simply choose where we're going to be distributing these goods. And we choose the pediatric department, which gave us the request. Now you quickly see a list of all of the different products which you have available with the current stock quantity. So this is up-to-date stock quantities. And the first item we're going to issue is the cefixime. And we want to issue 100 units of that. We see it's the first on our list, so we easily identify it. We have 7,000 units in stock. We choose the quantity. We enter 100, and you actually do that on your keyboard and on your device. And we click the validation check mark there. All right, so then we have our stock was adjusted from 7,000 to 6,900 immediately, and the quantity being issued is 100. For the second item, we're going to use the barcode scanning. So this is the second way that you can actually issue. So we choose the barcode scanner there at the top right. You open the camera on the Android Capture, and you scan that barcode. And once you scan that barcode, the item is immediately brought up, and you see we have 9,600 units in stock. We want to issue 150. Again, we click on the validation. We see that our stock has been adjusted to 9,450. We're issuing 150. And that's our second of three items. Now for the last item, I want to simply scroll through my list. So I click and empty the search bar. I get my full list once again. In a facility where you have maybe 50 items, it might be impractical to scroll through, so you're either using the barcode scanner or search. But here we have fewer items. I see that the face mask is my last item. I have 40 in stock. I want to choose 3 of them. I click on the 3 there. And I have my 3 items there listed with the adjusted stock. Once I've picked those from the shelf and I have them laid out on a table in front of me, I'm about to issue it to the department. I click on my review button. There's the review of everything being picked and the quantities. That's correct. I click confirm, and that's immediately registered. So I have just conducted, with a few clicks, scanning or searching, issued all of these items, and once I synchronize my device, that data is available on the server, and in case of an integration with a central system, it can also give the direct quantities. If I happen to go through below an order level or even to 0 stock, I can generate an immediate replenishment. In the case of an integration, not saying that this is done automatically within DHIS2, but it's the ability to have this real-time data using this tool. Now there are a couple other workflows which you can go through here as well for stock correction and discard, but I'll let you go through that on your own and just see how that can be done. It's even less clicks when it's for those different workflows. And the focus really is on making that process of issuing and managing transactions much easier for the health worker at the facility. All right, so that was the real-time stock management tool and that first step. Second, I'll go through one more workflow, which is the cold chain appliance inspection. So this is for the cold chain equipment. So we'll choose that one here. Now this is for managing freezers and cold chain equipment, capturing if it's functioning, if there's any need for repairs and so on in the different stages which I mentioned. I'll show you all the ones available there that we've configured. In the same way you go into your Capture app, we choose the Cold Chain Appliance Lifecycle Management program. And here we have a list of all of the equipment or all of the cold chain equipment installed at our facility. Here we want to conduct an inspection of refrigerator number 2, which we see there, refrigerator 2. We click on the drop-down, and we get a full set of attributes that have been configured for that device. Some of them were already integrated with the PQS, so the PQS code and category, type of appliance, manufacturer, the energy source, also the storage capacity, and so on. And all of these attributes can be configured and added as needed for reporting. So we'll just go back into our refrigerator number 2. And here we see all of the different stages that we've configured, from transferring or installing the appliance. Those are the first 2 there. Conducting a manual temperature recording, so you have that within the system and not simply recording it on paper. The inspection, which we'll conduct in just a minute, but also conducting preventive maintenance, monthly maintenance, registering appliance alarms, which is another WHO requirement for this type of equipment, that all alarms are registered. Conducting a repair request. Any corrective action or any kind of repair that has been made can be captured there, all the way to the disposal of the device and the end of life. So now we're going to conduct an inspection. So this could be a daily or weekly inspection, simply showing if the appliance is functioning or not. So we click to open that and create a new event. We add new. We confirm here the date. We conduct the inspection. So we look at the equipment and we see, is it functioning? Is anything damaged? Is it on fire or not? And once we've conducted the inspection, which may take just a minute, we click yes, inspection complete. We see that the progress bar has increased. And then we confirm functional or non-functional. And here the equipment is functional. Very simple. We save that, we complete the event, and that's immediately logged. All right, so once this is done for all of the equipment that's registered, you have a very clear and up-to-date picture of how much equipment you have that's functioning or non-functioning within the country. Same for the alarms and alerts. And you can build then analytics on that to have a clear overview, not requiring to do a manual inventory each time you want to see the status of your cold chain equipment. Similarly, we have another one. I don't have the workflow configured here, but just to talk through it, the cold chain appliance repair request. So any facility can create an event to request repair. So you need specific repair. For example, the compressor on a fridge may be broken. Your vaccines are in danger. You make a repair request. You can add images. You can write what the issue is. And at a district level, where you may have a specialized cold chain engineer or technician, they can have a line list of all of the repair requests from the facilities with a description and images of what the issue is, and they can plan their rounds to conduct any kind of repair or maintenance that needs to be done in all of these different sites which they have to travel to. So this is the type of workflow support that we want to build into this tool to be able to have visibility and also this kind of operational decision-making and work planning, in addition to the strategic decision-making with the repair and rehabilitation of the equipment. All right, so this is for the cold chain equipment management. And for that, you also have the weekly preventive maintenance. And as I mentioned, for the real-time stock and also for these, you can go through these workflows without needing to download the app and logging into the instance. Simply using the web, going through the website, DHIS2.org /logistics, and demoing that, going through the exact workflow that you would be doing otherwise with the app. All right, now moving on from this, what can we do with this data that we're recording? Now what I want to show now is just the dashboard. Now this is yet another instance which we've created with some demo analytics, and we have quite a bit of dummy data for most of the visualizations here, but there's very often requirements for reporting on the data that's being collected, and we have this request for real-time data and having up-to-date information. So what I want to just quickly show you is what we have on the demo website for the logistics. So we have a dashboard for CCE, so cold chain equipment, and here, oh, I think I have to log in again. Okay, great timing. Let me see if I can access our development instance. I think the timing of the backups and so on don't match the time zone we're in now. Okay, let me see if this one is working. 1 second. All right, this instance is up at least for now. I think it will also start restarting or backing up soon, so we'll use it while we can. So on the other instance, it's a public instance. The login and password are on the front page. As soon as you reach that login page, you'll see demo and the password, so you can log in and go through pretty much all of these same dashboards. So just to quickly show you what you can see here, it's the cold chain equipment dashboard. And here you have multiple visualizations that can be built using what I just showed you, the cold chain equipment management tracker program. And this is when you capture data, you can actually show that, temperature data, you can actually show that on a graph and have this kind of information and report. We don't have nearly as much dummy data developed. It's a lot of data that we need to produce for these visualizations, so that's not as complete for the cold chain. But you can see different alerts and thresholds, inspection reports, and the number of equipment that's functioning or not functioning. Specific request we had also just at the end here is different donors that have provided different pieces of equipment. So you have the count by organization and where that equipment is currently being used. So you have quite a good overview of the different analytics that can be made with the cold chain equipment management. Now second, and here we have quite a few visualizations, it's the monthly stock report. So we have district level analytics, monthly stock report, health facility level, provincial level, and national level. So if you go through these different dashboards with monthly stock report, you can quickly see what you can do with simply reporting your monthly stocks with those few data points which I showed in the beginning. Still using your stock card and bin card, but having that monthly stock in DHIS2, you can quickly see your stock availability. So for this facility that I'm in, I see that 92% of the items that I have are currently in stock. I can see that that 8% represents these 4 items that are currently out of stock. Very quickly, I see and identify issues that I have to treat immediately. You're not simply reporting on the stockouts, I mean, you're doing that as well, but then you can identify which items I need to immediately replenish if I want to continue providing services. For that, I see here for September, for my stockout, I have my infusion set is out of stock, permethrin, adhesive tape, and tongue depressors. Okay, so a couple of those are not crucial but important items to replenish if I want to continue providing a full set of health services. Here for my stock availability, I have also a comparison for the last 12 months that my stock availability was a bit low, but over time it's improved. And you can see these trends on how the performance is for your stock availability and how you can quickly both report but also provide operational information to correct the issue where needed. You can look at how different items are affected. Here you've had for your vaccines, measles vaccines, we've had 5 different instances of stockout within the last 12 months. and this is really showing performance over 12 months for the stock out. You also have stock coverage time distribution. So from stock out to overstock and different amounts of stock coverage. So you have 0 to 1 month of stock for 8 items. For 5 items, 1 to 2 months of stock coverage time. You see how well that is distributed across all of the different items over time. And you can also quickly identify that perhaps for my items with over 3-year stock coverage, I need to maybe redistribute that, move it to a neighboring facility that maybe is understocked, and that way optimize the stocks that I have available. Multiple other things. Here you have coefficient of variation. This is just showing the variability of their demand for any one product. Is this a constant request or very stable with low to medium variability? Or do you have high variability for a single item here? And for any of these that may be a bit more complex to understand, we can show details. This is something which we saw also in the visualizations and analytics session in the first day. Of course, problem loading. We have here, you can open the details, and this was working just as soon as the instance is back online, you'll be able to see an explanation of what this means. So it will explain how the variability changes from item to item, and that for items with high variability, maybe it needs to be investigated why that is. Could it be due to a seasonal issue where it's being used more in the past few months than in previous months, or to some kind of supply availability? But for any one of these, you're able to open up and have a detailed explanation of each one of these different charts, how they can be used and interpreted, and how they can support actual decision making for the supply chain. Further down, you have more detailed information then. This is the actual raw data being collected for the stock received, distribution, and so on for each specific item and for the past few months. All right, so this is just specific key indicators and visualizations that can support both reporting and decision making. This was health facility level analytics. And if we look at visualization library, 3 minutes. All right, so we can actually go through really a very, very extensive list of possible visualizations that can be built simply with monthly stock reporting. So here we have section 1 with stock data, and there are 7 different sections with different types of visualizations and data that can be shown with the monthly stock reporting. Everything from stock availability and multiple variations on each one of these different indicators and visualizations. Lastly, maybe I can show the district level, which will then have, let me see here, district level here. Now we went from the facility level showing the stock availability by item. I can also see how, here we've limited our district to only 4 facilities. We can see that within that district we have 13 stockouts across the 4 facilities. I can see which of those facilities have stockouts. I can identify which items those are, and I can plan for a redistribution. So for a facility with an overstock, I can move those to a facility with understock or stockout and quickly remedy that problem. So we're looking not only at reporting aspects, but also operational aspects to reduce the amount of stockouts. Due to then the limited time, I will share this, and the links to both the tutorial and the walkthrough as well as the demo instance are available in the presentation. But I think I will then use my last few minutes just to go through some implementation considerations, all right? Just to move into presentation mode here. So, to start, what are your stock data needs from facility level? Are you looking to have detailed data from a few sites? Do you want to have the transactional data from high volume sites? And that may be the case. Or are you looking for key data, so having the stock on hand and your consumption levels in order to remedy and improve stock availability? What are you looking to identify and actually fix within the overall supply chain management? I think that's a good first question to ask. Secondly, what capabilities or what capacity do facilities have to use separate systems? Are they able to manage simply the stock reporting, and that may be the case, that they continue to use their paper-based tools which they're comfortable with using and they're familiar with? Can they move to a transactional system using DHIS2, as I mentioned, with the stock management tool? Do they want to have a full-fledged ELMIS with all of the different implications that that entails? And the answer may be yes to any one of these depending on the context, but it's very important to identify what is the capacity within the facility to implement the same system or a separate system or a new system in order to capture that data that you need. Then what is the objective of that implementation? Is it reporting to donors the number of stockouts, or is it actually improving that stock availability and reducing the number of stockouts? It's likely both and more. What are the requirements that you have, and how is that linked to operationalizing and improving the management? How is DHIS2 fitting into this overall landscape with these needs that you have, the competence you have within your teams to be able to implement any one solution and actually sustain that over time? So looking at a total cost of ownership, how much will it cost to actually implement and maintain that system and keep it running over time? Also, I mentioned just now total cost of ownership and sustainability, but what is the holistic approach? Is this targeting a single program, which may be how it starts, perhaps only for immunization and for vaccines, but what is the possibility to expand that to multiple programs? And a lot of the approach that we're showing here, it's looking at holistic supply chain management, not simply targeting one or another program, though it may start that way, but we're really looking at having a data set from the monthly stock reporting to the real-time stock tool to capture data for all products that supply chain teams can look at those in a holistic manner, not limited to a single program. And then lastly, what are the limitations for DHIS2 for logistics management? We're not recommending it as a central medical store or transport management or for procurement. It's really digitizing that last mile, connecting it with a central management system, being able to provide strategic and tactical and operational decision-making to improve that level of management at the facilities. All right, so a very clear and defined scope of implementation. Last 3 slides. So overall outcome, improving supply chain management. How are you actually improving the availability of medicines to then improve the overall health outcomes? How are you using the stock data and comparing it and analyzing it beside health data to be able to improve the overall health program management? And then lastly, and this one we can also take offline and in the breaks, how do we fit in with all of these other tools? Here you see just a few of them, just 8 different ones mentioned, but there are actually hundreds out there. There's no lack of tools or features available. The ability to successfully implement them at the last mile at health facility is the key issue that is being faced. It's not the quality of the tools, it's the ability to implement them successfully over time. All right, so thank you very much. Please feel free to come speak to me in the breaks. I can share all of this information and more, and then have individual discussions on what your needs may be and how you fit in to this DHIS2 for logistics approach. All right, thank you very much.
Thank you very much, Bruno. Maybe we can take only just one question, if there. Otherwise, maybe we can discuss in the break. So, any question? Yes, please. Good morning. This is exercise morning.
Thanks a lot for your presentation. Actually, in our country context, we were exactly looking for this use of DHIS2 for cold chain logistics and also vaccine logistics as well. Right now, we are going through a difficult time when the government partners, implementing partners, particularly the immunization team, they have tried for the past 5 years using M-Supply, and the data collected is accuracy only at the provincial level, and at district level it is quite complicated. However, when it comes to DHIS2, they're quite comfortable. It's interestingly. So especially we need also vaccine logistic at the health facility. Actually, I'm talking about both cold chain and vaccine logistics. So maybe I have missed what you have mentioned about vaccine logistics. Is there any possibility also to extend this to also vaccine management?
Okay, thank you for that question. It can definitely be used for vaccine logistics. We have this also integrated with the EPI metadata package, which we've developed. For vaccines, there's a few disaggregations there with open vial wastage and a few other needs that can be built into the monthly stock reporting. So it's entirely thought into the system to be able to have that kind of information also available for vaccines. Yeah, just small differences. And for the cold chain equipment management, I mean, it's started, it's been piloted and is being launched, so to actually have that overview of the equipment, so those two should go hand in hand. You didn't mention, but I know you're thinking of it, temperature monitoring and having that integrated as well. There's been some changes with the WHO requirements, with the new PQS, EMS standard for having integrated temperature sensors from the manufacturers, so not having a separate device. So we began piloting, integrating with temperature monitoring, but now what we're looking to do is partner with organizations with competence to be able to connect directly to these sensors already built into the to the devices from the manufacturer level. So for the time being, the temperature monitoring is still manual. You would have to input that as a stage, but we hope to have that integrated as a out-of-the-box solution meeting this new standard. So, but for vaccines, equipment, definitely covered, and hopefully automated for temperature in the future.
Okay, thank you very much, Breno. Anyone? Yeah? Okay. Maybe another question.
Thank you for the presentation. My question is, there are countries that have oversight, you know, the major procurement come from the national level. The oversight to the provinces are very important. So if the system is it's for the districts and the facility, how do the province, the national have an oversight in terms of the stock out data flowing up to the national level?
So we're not recommending to use this to capture the stocks and the stock management at a provincial warehouse. A provincial warehouse and a national warehouse, a central medical store, has quite large quantities, and the requirements are higher than what we would recommend to use DHIS2 for. So clearly, if it's only for the provincial level store, which should be a larger store shipping to many facilities, we would recommend to have a supply chain management tool. I know M-Supply was mentioned, for example, that type of tool, because it does reach the limitations of what DHIS2 can provide. If you want to have oversight over the facilities within a province, that data can be aggregated. That's entirely within what DHIS2 can deliver. So you can have your overview of stocks for all facilities aggregated by province, nationally, number of stockouts, your stock coverage time, all of the indicators which I showed. And if you go into that demo site, you'll see health facility level, district level, provincial level, and national level, and how the different visualizations are aggregated or how they change at those different levels. But for the actual management of the store at the provincial level or central store, then we then recommend having a more specific tool for that. Sure. Yeah, within the site, I can show to you also in the break how we can have the overview of the entire stocks available in the country for any one product for every facility that's reporting. So for example, that's a possibility. So you don't only see what you have available in your central medical store, but what is the total quantity available for paracetamol in all of my facilities.
Okay.
All right?
Thank you, Bruno.
Thank you, and yeah, look forward to speaking to all of you.
Yeah, thank you. Maybe some discussion in the break is also welcoming. So before going to the next session, just let us welcome Antu from WHO headquarter. So just stand up and say hi. Thank you very much. And the next session is DHIS2 offline functionality.
Okay, everyone. So we're going to talk about some of the offline features in DHIS2, and this session is going to be split up into two parts. So I'm going to start us off just by discussing some of the core features, and it's going to be pretty quick, I know, because it's already 10. And then I'm going to hand it over to Sam, who's going to talk about a custom application that they have made in order to support some of the offline features, which is a good example of how some of this extensibility that we spoke about on the first day can be applied to kind of assessing or kind of handling a real-life practical problem. Okay, so I'm going to go over both a mix of web features and Android features, and for some of you, you might be aware of them, for some of you, you might not. I'm going to touch on aggregate data entry and how that works, also offline dashboards, which is a relatively new feature, and then I'll discuss the Android app, and I'll just walk through some of it real quickly in terms of aggregate data entry, tracker data entry, and some of the local analytics, which I think is maybe something new for many of you in terms of the various visualizations that can be used and viewed offline. So I'll start with the aggregate data entry. So for aggregate data entry, you can work offline both in the current and the new version of the data entry application, and I'll show it real quickly. Basically how this works, data gets cached locally on your computer, okay, so on the device that you're using when you're offline. So the web browser or tab that you have open, if you go offline, it must stay open, right? And then once the connection is restored, the data can be uploaded. Now, I'm not able to do a live demo of this because, of course, if I disconnect from the internet, it's going to run, we're going to have some problems with all the conference setup. But what you'll see here is that I'm currently offline, and there's this message at the top that you are offline, data is stored locally. So I'm entering the data offline at the moment, okay? And the data gets saved on my computer at this point in time. Okay, and then my connection is restored. So then I get this pop-up, there is data stored locally, please upload it, okay? Then I click on the button, and it'll upload the data to the server itself, okay? So there is a little bit of action here in order to upload the data that's there. Now, when working offline, you can switch between organization units that you have loaded previously. But if you try to open a part of the hierarchy that you haven't accessed when you were online, it won't open. Now, you have to be careful here, because if you're moving between organization units and you hadn't loaded it previously, the previous data won't be there either. So you have to make sure you're entering into organization units where there is no data, unless you will run into some problems. There will be conflicts when you're working offline and try to upload that information. So just be cognizant of this. This is not really what I would say a long-term solution where you kind of are offline for days at a time. This is more to kind of help you with intermittent connections, I would say. So this is the new data entry app, and things look a little bit differently here. So I'm offline here. You get a little indicator at the top that you're offline, and it's entering data here. And it'll just save that same way locally on your system. And when you get online, it just uploads the data automatically. So there's no action you need to take. It just gets synced. So I move from offline to online, the little indicator there, and then the data gets moved online. And same type of thing, you can move between organization units, etc. They have to be previously loaded. You can see here in this example, it'll tell you that it can't load those other organization units because I'm offline at the moment. Okay, so just as a quick summary, you can enter data offline in both the current and the new data entry applications. You can change organization units that you've already loaded, but be careful because any data that you haven't loaded would not be there. Okay? You should not close the tab that you're in if you're working offline. So, you know, if I have this open, I don't want to close it, right? You can close your computer or whatever, you know, put it to sleep, but don't close the tab, don't close the browser. Okay? And like I said, it's meant more to combat intermittent connections rather than a permanent solution for working offline. I'll touch on that, and we'll have Sam also discuss this in a bit more. It will not work either in incognito or private modes. So, you know, sometimes we talk about this clearing the cache and all this other stuff. Don't clear your cache if you have data stored on your computer, okay? Because then it will be removed. We also have some functionalities for offline dashboards. Basically, any of the dashboards inside of DHIS2 that you make can also be saved and stored offline. And this is a bit more longer term, actually, than the data entry. So these are stored in cache, and as long as you don't log out of DHIS2, you can close your tab, you can do anything you want, as long as you save the link, and you can load that dashboard again. Okay? So how this works, this is a dashboard in DHIS2. There's this button here, and I can make it available offline. It'll store that dashboard, okay, locally in my cache. Same thing, I'm just doing it for another one here. And you'll see an indicator here, I'm currently online, right? So I have to be online to start this process. But now, when I go offline, you'll see here any dashboards that aren't saved, I'm not able to access them, okay? But the dashboards I have synced on my computer, I am able to open those up, and I can review all the various items that are on that dashboard. Now, there is an indicator over in the corner there. It'll pop up here in a second, where it says when the data was synchronized, right? So because you're offline, of course, these dashboards are not going to update with the latest data that's online unless you restore your connection. Okay, so it could be a couple days or whatever that's indicated, depending on the time you've been offline. When the connection is restored, the data will synchronize again for that dashboard so you can view the latest data. Okay, and like I said, the nice thing about this so if I close the browser, as long as I have the link, I can open it up again, okay? So as long as I don't log out of DHIS2, so I could be offline, I could close the browser, I could close the tab, whatever I want to do, okay? I just maybe bookmark the dashboard page, and it'll open it up again. If I do log out of DHIS2, then I won't be able to access that anymore, okay? So just be cognizant of that if this is something that might be useful to you to use in an offline setting. Okay, and then of course, when you're done with all this, you can remove it from the offline storage as well, using the same kind of context menu. Okay, so outside of the web features, our more permanent solution, at least for the core of DHIS2, you know, Sam will talk about some alternative options through extensibility, okay? But in the core of DHIS2, our kind of permanent action in terms of addressing offline functionality is via the Android application. So we support both offline data entry for aggregate as well as for tracker, okay? So it works offline, and you can stay offline for, you know, quite some time. You can then synchronize when you have an internet connection. The interesting thing, there is a lot of features or functions that work offline that maybe can be quite useful. So for example, for aggregate data entry, all your validation rules will work. For tracker data entry, you still have duplicate detection. So if you're entering a unique ID that's already been entered into the system, or someone's name, it'll do that fuzzy matching and still tell you that that's the case. If you're generating unique IDs through DHIS2, you'll still be able to generate those IDs offline. It will reserve unique IDs for you to utilize. So some of this kind of is taken care of when you're looking at the Android app. So I'll just open that up. This is going to be hard with the mic here. I'll try my best. Okay, so just turning off my internet. I don't have any internet connection currently. Okay, and what we can do is use both the, so when you log in, and I apologize, it's not super clear. Yeah, okay, thanks, John. Just let me go back. Okay, so what we have when we log into the Android app is a mix, depending on your system, of both aggregate as well as tracker, aggregate datasets and tracker programs. And you'll see the text, and you don't see it super clearly here, but it'll tell you if it's a dataset or if it's how many tracked entities are in your program, essentially. And because I'm currently offline, what it's done is synchronize a certain amount of tracked entities or datasets to my Android device for me to work on. And we can set these parameters, and I'll show that really quickly in terms of where we can set this up, because you can decide for a specific program, let's say you want to download, 500 tracked entities to the device. It'll then download the latest 500, store those on your device, and you'll be able to work with those offline. So if I just open up an aggregate data set, so I'm able to work with aggregate data that's already been entered on the web. I can also then edit it on my device, or I can make new entries on the device itself. So just open up one up that's already been there. So you can see when I go to save this, it asks me if I want to check my data quality. What this means basically is that it's running my validation rules for me. So I can check these validation rules even if I am offline, entering data. I can save this data on my device as I enter this on here. Now, one thing about Android in particular, it doesn't support any type of custom forms, so you have to use either kind of section or default forms inside of DHIS2, and we do recommend that these are not very long forms, maybe 5 columns maximum, right? Because even if you're in landscape mode on a tablet or something like that, they could have a very small tablet, they could have a phone that's very narrow. So you don't want to be having too many data items when you're using this method to collect your data. For example, if you have a form with 20 columns, that won't really work very well on an Android device. There's a lot of limitations in terms of how you scroll depending on the screen size. Okay, so we also support tracker data entry offline. And like I said, I'll just enter a person. Okay, so I can register that person. It will generate, so it might be a bit hard to see, but there's this child number here. It still generates those IDs if you're using some type of automated system-generated ID in your program. It will do that offline. Okay, it also will do duplicate detection offline based on what's stored on your device. Okay, so I've entered a local ID, and it's telling me that there's somebody with this ID already registered on my Android device. So it's not actually going to allow me to register this new person. It'll do the same thing if the names are the same or something like that. Okay, it'll do that duplicate detection while you are offline. So I'll just enter some more information. Okay, I can add new events, I can schedule events, I can make my referrals and transfers, I can make relationships as well. So I'll just do that quickly. I'll just add a little bit of data, and I just want to show you a bit of information. So one thing unique to the Android device, it's not really an offline feature, but you can see that for some of the option sets, etc., I can make visual configurations and assign, for example, various icons to my options. I can have different layouts for how they appear. So instead of showing as a drop-down, they'll show as an icon, for example. So I'll just quickly save some of this information. Okay. Now, when you're offline and you want to restore the data, of course, you can't sync the data at this point in time. It'll give you a message, you're offline, you're not able to do that. So when you have your internet back, I'll just restore my internet connection. Okay. And you can sync from many different places. So you can sync from the tracked entity itself. Let's say you've entered 15 records for your day. You can also do it from the home page, so you can sync all 15 records at once rather than doing it one by one. There's many different places to do this. So I'll go ahead and send this to the online system. And we'll just give it a moment. Okay, it says sync successful. So we'll just double check. Okay, and here's this person that I entered on my Android device. Now I can access them online, and I could continue my workflow if I needed to, or someone could do some follow-up or checkups, whatever needs to be done, or I could, of course, keep entering information on the Android device for this particular person. Okay? So the other item that's quite unique, and I'll just touch on quickly, is the ability to add local analytics on the Android device. So let's say I have 200 records on my device, along with 10 data sets for each org unit that my user is assigned. They're assigned 3 org units. They have 30 data sets accompanying for each month that they're assigned for. So there's a lot of different features actually for local analytics on the Android device. And what it's going to do is just use the tracked entities or the data sets that are stored on your device and generate various indicators or various outputs from this information. So for example here, I can display various types of visualizations offline on my Android device. It'll use local data. We support various visualizations. I have a link to the visualizations that are supported in the app. Oh, sorry, closed it completely. Okay. So if I go to the tracked entity or tracker program, let's say, I'm just going to open up one of these records. Okay. And you can see here we support a lot of different pieces of information. So you can have various information for the individual case. You can have various parameters defined where you can review them quickly. You can have also various types of visualizations supported for the individual, right? So we support both aggregated information as well as kind of individual information directly on this patient dashboard. So there's an example here of the growth monitoring chart, for example. We have their weight, we have their temperature, any type of numerical data that you can map over some period of time, you're then able to create visualizations for these individual records. So these are automatically created once they're configured for every person that is in the system, basically. And you don't have to be online at all to generate any of this information. It's all generated and stored locally as well. Okay, thanks, John. Okay, so just real quick, for those of you kind of interested in I've shared some resources in the presentation. We have an accompanying web application called the Android Settings app, and here's where you define a lot of the parameters for working offline. So for example, if you want to add in those visualizations or create any of those dashboards that I showed, you set them up here. If you want to define how many tracked entities that the device that are stored on the device when a person syncs, you do all of that here. So as an example here, I have some global settings, and I can say how many tracked entities do I want to download on the Android device. I can also do it by program, okay? And I can say, for example, I want to download 500 tracked entities on the device, or I can change this, of course. We don't really recommend more than 500, but there are obviously exceptions to these rules, okay? So same thing for all of these. Sorry. So same thing for all of these visualizations. So we just create them in Data Visualizer like we would normally. Oops. Right? So we're just taking visualizations we've made in Data Visualizer, and then we're adding them to the dashboards. So I didn't actually show for aggregate, but you are able to create multiple dashboards on the device. So you can see here I have one for infant and young child feeding. I also have one for ANC contacts as an example. So you're able to create multiple tabs and have multiple dashboards stored on the Android device, and it will use the local analytics that are stored basically on that Android device in order to display this information. So a person will get real-time updates as they enter more data into their data sets, or as they add more tracked entities to their programs. All of these analytics do get updated on the device as well. Okay? So we use the web to set all this up. You know, you create your visualizations here just like you would normally, and then you're for aggregate data or for tracker data. Okay? And then you just kind of add them through this Android settings web app, and you're able to kind of add the visualizations that you want to see. Okay? All right, so this was a bit of a crash course just on some of the core features that we have. So once again, we support offline dashboards through the web. We support aggregate data entry through the web. And through Android, we support both aggregate and tracker data entry. We also support all of these visualizations that I've shown, and they all work completely offline. They're all updated offline as is required. Okay? And Android is more of our, let's say, permanent solution for working offline, whereas for the web, it's more for combating intermittent internet connections. So what I'd like to do is ask my colleague Sam to come up, and he's going to talk about an application they've made to deal with maybe more permanent offline, a more permanent working offline when you're using a computer, right? So not just a mobile device of some kind. Okay, so Sam, please welcome you to the stage, and you can walk them through the application you guys are working on.
Hello. Hello, hello. Okay. Okay, good morning, everyone. So for me, I also would like to show you a different approach that we are doing for the offline. But before I go to the demo, I would just give you a bit of the background of what we are trying to do. And importantly, I would like to mention that what we are doing is not a separate thing, it's built up on or extending DHIS2 the core the core platform. Let me quickly go through the problem we are trying to solve. So what we are doing or supporting the ministry, there's one project that the ministry would like to collect the household information. Basically, the health worker, they will need to go to every village as part of their activities. They will visit every village in the catchment. They will do kind of the survey, how many families living in this village under my catchment, and then all the demographic details or the census detail, like what kind of water are you using, what kind of toilet, latrine are you using. So that's what they would do, and these activities have been going on for almost 10 years, and usually they use paper to record those information. And originally, the name of the project they call family folder, as you can see, because each family will have one folder. and they will store that in that paper to collect all the information of that family, and then the next family will have another folder, and as you can imagine, if we have 10 families, we have 10 folders in that health centers, which we think is not really sustainable. So every time you need to carry that folder, you cannot lose it. And this is what we are trying to help and to solve, so you don't have to print more papers, and then you can reuse the information you already collected from previous years and continue the data collection. Another one, because like I mentioned, Laos has been using DHIS2 for almost 10 years now, and there are many donors like UNICEF, WHO, also supported the devices, the equipment. So there are many kind of devices available at different level of the facilities. And health workers also already familiar with DHIS2 and tracker. They are using tracker for field programs like malaria. Now they are also using for immunization. And most importantly, because the health worker needs to visit every village, right? It's important that the internet connection has to reach those areas, but in reality, it's only about 60% that you get the internet coverage. So for 40%, you still need to have the offline solution. So with that, in the context, this is what we are we come up. So as you can see from Nick, because we need to have offline, and offline also already have some tools for that. So for web, as Nick showed, you can do for aggregate, and dashboard already works on offline. For Android, it's also working really well. For you can do aggregate, you can do event tracker and analytics. But in our case, maybe Android might not be the best solution, and then since the web is not supporting tracker, then we think it should be another way to do it. The second one, we want to be the seamless switch, right? If you have internet, you can use online. If you don't, you use offline. But you don't need to switch, right? For example, if you use the web, if you want to use for online, but if you want to do offline, you need to switch to Android. You need to know how to operate the Android app. But for these activities, because it's also not very frequent, it's about twice a year. So if they're already familiar with the online, then they can continue with the same workflow offline. That will be better, so you don't need to train again. And as I mentioned, because many parts of the country will be supported by different donors, and different donors will support different devices, right? You have maybe the laptop, PC in the north, you have the mobile in the middle, and then you have the tablets in the south. So we don't want to start procuring more devices. They already have. And if we adopt for Android, then for those that don't have the Android, then you need to buy it again. So what we want to do, what you have, we would like to reuse that one, and then you can continue with the data collection. And the last one is we would like to have the capacity to maintain it. Like we don't have the big team, so if you do Android, maybe you need another dedicated team to not just to develop, but to also support the Android. You need to know Android very well, how to debug and all. But we are using is the web technology, so we can use the same team that we have to develop and also to maintain. And this is what the solution we are using. So we call the PWA, or Progressive Web App. It's quite a new technology. Not sure if many will be familiar with this, but basically it's just a web technology that you can use to use it as an app on the mobile. But in a nutshell, you can think of it as just a box of Chrome running behind. So they have more functionality like offline, but behind the scene is using all the Chrome technology. So any device that can run Chrome can use this approach. Okay, so now I would like to switch to the demo. I hope the screen is still. Okay. So as I mentioned, it works on web, on the PC or the mobile and the tablet, but I would like to show the tablet one because that's what Lao is using a lot. But before that, from the Android, as you know, right, if you want to have to install, you need to go to Play Store, you need to have account, then download the app. But for this, we are, like I said, we want the seamless experience, so you just use the online, the same workflow. So what the health worker needs to do, and this is just one-time thing. Right? So first you just go to the app. So the app is made using PWA, the Progressive Web App, but it's also built on top of DHIS2. So it's not something outside and a separate app. So what I will show, I cannot see the marker, but it's okay. So I will just select this app. We call it Family Information App. So this is one is still online, right? So if they are comfortable, they have the connection, they can just use online and continue. You don't have to worry about, should I use offline, should I use online? So if they have internet, they can sync and then it should be okay. And this is my demo account, so I just assign this to be responsible for these 3 villages, so I can just select one. And as you can see, in the past, you have this information in the folder, right? And they just did the new one, the latest one in 2019, where they recollect all the information into DHIS2, and then they stop all the papers, and now we will continue with the online one. And as I see, now there are many families registered in this on DHIS2. I can just quickly go to one family, what kind of information we collect. So we have the information. I'm not sure if it's not very clear, but as you can see, so basically this is the family members, right? So what we collect, how many members in your family, at least name, age, any insurance are you using, but also the information of the family, like any birth, any death happened in the previous year, what kind of water you are using for drinking, for example, and all. But now I would like to use this one for offline. Let's say if next month I need to visit the second village to update the information for 2024, right? And I know that this village will not have internet. So what I would do from Chrome with PWA, if this app is customized with that, you will have this option to, on here, say install app. So this is part of the Chrome, so it will ask if I want to install. Yes, I want to install. And if I want to add this to my home screen, yes. And now going back to my home screen, you will see just like the Android app, but now it's running with Chrome with the possibility of using it offline. So I will also open my app now. Take some minute to load. And as you can see, now it's the same thing, but running on the PWA. So same UI, same workflow, so I just need to continue with that village. I can see this. But now, if I want to use offline, there's the talk button there. Yeah, there's a button there on top. It will say offline or online. So now if I want to switch from online to offline, then it will ask me to which village you want to download, because you need that information in your device, right? And in this case, we also limit the number of villages you can download for one time. We don't want you to download all the villages. We are not sure if your device will be able to accommodate that size of data. So you can select at least 2 or 3 villages, but for this demo, I can just select one. Oops. Yeah, let me try one more time. And then click on download. It will take a few seconds to download all the data to my, in this case, my tablet. Yeah, based on the size of your data will take some time and depend on the number of villages you select. So now it's already downloaded to my tablet. I can click on OK. It will refresh a little bit. And now if I can select the new village, now you will see. And the toggle, the button up there is also switched to offline mode. And now I can continue. Let me switch off the internet for this tablet. And as you can see, right, if I select the village that I didn't download, you will not see the information, but only this village that have it will continue with all the information. So what I can do now is I can either update the family's information. For example, this is the family that already collected. I want to update the information for 2024. I can select 2024. Let's see if we have, for example, we have 6 members. We want to, now the family has 1 more member. I can type it. And then all the information that is required, you can just select, maybe just to save some time. And then the status, which I can talk more into detail if you are interested in this case, because about the population movement, we can also use this to check if this member already transfer or move to somewhere else. But for me, I would like just to show the offline thing. Okay. And as you can see now, we have new members for this family. So next one, I would like to try to add another new member, new family. Let's say this family is 1, 2, 3, 4. That is family already registered. What's the book number? And let me just add 1 family member. Head of the family. Yeah. So now I successfully add 1 member to this family and also registered the new family. So what I can do now, if I finish my activities and I come back to the facilities where I have the internet and I'm ready to send this data to online, then what I can do, there's a button there for pushing this data to DHIS2. So I can just do that. It will tell me how many data points that I entered. So I don't have internet right now, but it will also tell, yeah, you need to connect. So let me just go back and connect my Wi-Fi. Okay, so I will do it again. It will tell me how many data points that will be pushed to DHIS2, and then now I have internet, it will push to DHIS2 and refresh, just to clear that that all the data that I saved locally already in DHIS2. So now let me go back to the online. Okay, refresh a bit. And go back to the second village. So here you can, there will be all the information here, but then I just need to search for the new family that I just entered. And there you can see it's already in DHIS2 online. Yeah, so that's basically it for the demo of how we using another way of implementing offline using the same DHIS2 core functionalities. And As you can see, this one is quite a unique workflow, right? It might not work with other countries really well, but it can be customizable. And right now we are working with HIPS India to implement the same thing in Bhutan. So if you are interested in learning more about this one or would like to see if it will fit to your context, you can always contact us at HIPS Vietnam. And we'll be really happy to show you more in details of the demo and what it can be done in apart from this. Yeah, so that's how I would wrap up my presentation and demo. Thank you so much.
Thank you very much, Sam. Maybe we can take one question and go for the tea break. So is there any question? Yes, Sam.
I have a question for Nick. Nick, is it related to any version or this offline mode? Is it related to any version or it's not related to any version for DHIS?
What? I'm sorry, what do you mean is related to the version?
You mean this offline mode? Is it related to 3.4 or 3.9?
Like when are these, the features I showed
Yeah.
available? Yeah, okay. So the offline dashboards actually was implemented quite some time ago. So I think it's like 2.37 or 3.8.
Yes.
And for the Android functionality, so one thing I should clarify, and maybe it's not always so straightforward, there are different versions of Android and there are different versions of DHIS2, okay? So the latest version of the Android app is 3.0 and the latest version of DHIS2 is 41. So actually, some of the features, depending on what you see, might not be supported in either the app itself or in the DHIS2 version itself. So everything I showed should work on quite a few versions back. In terms of the Android kind of sync and all the visualizations and everything, that has been around, I believe, since, I want to say 2.8, Android 2.8, maybe. So that's quite a, maybe 2 years back, I think. But they've added more chart types, etc., that work offline. So, but there's also this web settings app, which has its own, it's a continuous release. So it also, the ecosystem there, it's a little bit difficult to navigate because you need to make sure you have the right settings app, the right DHIS2 version, and then the right Android app. But I would say if you've done anything in the last 2 years, you're using anything in the last 2 years, it should work for you, yeah.
Second one is that for the dashboard, if I'm a special organization, I'm making some data offline, data entry, my dashboard related to my organization, it will be updated or no?
So if you're offline, your dashboard is offline, and you've entered data online, the dashboard does not get updated until you go back online.
Even
Right.
it's related to my organization.
Well, you can't, and using the DHIS2 front end, if I'm offline, right, and I enter data, my analytics has not been run. Okay, so the dashboard will not update. Yeah.
Okay, thank you.
Okay, take another question because we are late for the break. Please, introduce yourself.
Hi, good morning. I'm JP from the World Bank. I'm asking this question from a country perspective, exploring DHIS2. I took note of the features for the client health registry. And let's say we already have the client health registry up and running. Can we now download specific sub-lists of that client registry to specific mobile devices and operate in an offline environment? And then add the attributes there for, let's say, a nutrition project, and then later on synchronize that to the national DHIS2 instance. Is that even possible? Thank you.
Population is fine. So, like if I understand the question correctly, so you have the national client health registry somewhere, so you download it offline for one particular place, and you can add additional attribute, but you have to configure all the attributes what you need to add first, like just the metadata part. And then you can try to enter all the data offline, and then it can be synchronized. But only thing what we want to, what we experience is not about how much data you can try to download. It's because of your tablet or the mobile devices, what it can allow. So if you have a big hard drive, all things, then you can download as much as possible. But like just to make sure that like we support for all the devices, we always just say you can download only for these places. Those kind of settings can also be configured on the online side, on the DHIS2 configuration part, so that you can try to download it. And then you can enter all the things. What Sam told around here, because all this data was already in DHIS2. In 2019, they entered all the data manually from their paper book into DHIS2. And we didn't want it to print all the paper again. And that's why you just say, data is already there, use the new technology. When you go to the field, you can actually download, enter additional details for this year, and upload it. So that like we save the money for the paper printing, and also you're just updating the record. So then the workload for the health worker is much reduced, rather than entering the same information again and again, and then they have to import it. So that was what you're asking, is exactly like what Lao have done. Instead of like adding an attribute, we are like adding the entire new family and updating new records. So this is something which can be customizable for each and every needs. And we tried with the family information because it's too heavy. The similar kind of approach can be applied for EIR or for other program, because the data is quite small. Here we are calculating or collecting entire population. When we talk about EIR, we are talking about only 4% of the population, right? So if you're talking about delivery, it's 2% of the population. So if work for 100%, we can also work for all the other programs. And this was the trial run which we wanted to test, so it's working fine.
Okay. Thank you, John. Now the tea break time, please. Thank you all.
Yeah, just for the tea break, if we can be back by 11, like 5 after 11 maybe? Okay, and we'll start with the country presentations afterwards, okay?
What is it?
this? It's just sitting here. Can I use this very expensive MacBook for my? I mean, someone's just sitting here. This is very expensive. Why is my voice being picked up? This is very expensive. I don't know. Leave their $3,000 computer.
I think it's Sam. Sam or Anu.
Sam is there.
No, that's Dũng.
Anyway, okay, we'll use yours. Is the battery gonna last for the session?
Oh shit, this window.
Yeah, but your
How long?
battery- An hour and a half.
Hour and a half. Yeah, I think it should be. But let me turn off. So which slide you?
I'll queue up the slides.
Okay. Presentation. I think should be open in another tab.
Yeah. Yeah, let's open a new window.
Ah yeah, they have the multiple screen. We can make the multiple views.
Why are they picking up our, like when I talk I can hear it on the speaker. I don't like it.
Maybe it's here. Yeah, that's the reason. Turn off Zalo, turn off Unikey, turn off this one. Okay. Yeah, but you need to click on recording from your computer.
Yeah, I'll do that.
You need to hold, but hold on. That's fine. Okay. دير بالك يا حسام.
Yeah, yeah. خلاص. Yeah.
Okay. Now we will start with the country presentation, but maybe just wait a few seconds. People will come. We will start with a country presentation. Pakistan now. Yes, please, Adnan.
Thank you so much, Mohammed. So we have a large participation from Pakistan. So I'll be requesting Dr. Inam and our director from KP province to please come in, say a few words, and then we'll move on to HMIS presentation, followed by our common management unit's presentation. Over to you, sir.
Thank you, Adnan, and thanks for this organizing this conference. Before starting our formal presentation, I will just give you a background of Pakistan in 2-3 minutes. Pakistan is the 5th most populous country with a very devolved health system, where we have 4 provinces, 3 regions. So in this way, we are actually implementing, you can say, in 7 countries we are working, because they are all autonomous and they are all devolved. Over and above that, we have a huge health infrastructure, right from the health house at the community level to the tertiary care and specialized hospitals. So there are a lot of complexities. We have different vertical program with vertical MISs. But still, in spite of all these challenges and complexities, thanks to HIS, and we as part of government of Pakistan, lead partner on DHIS2 transformation, we have made significant progress in different provinces. Since I said we are, different provinces have different systems, so we are at different levels of implementation. The biggest challenge for us is the integration of all the health programs, MISs, including the tertiary care. Because currently we are working on the public sector, and we have a huge private sector as well. That is also a big challenge. Tertiary care is almost independent, they are autonomous, and they have their own MISs, which is also not standardized. So there is a long journey for us to have a well-integrated DHIS2 system implementation in the country. With these few words, let me invite Dr. Qasim, who is actually representing government of Pakistan, and he will give an update, and which will be followed by Fahad, and he will be having us some flavor of the DHIS2 under Global Fund programs of malaria, HIV, with more focus on TB. So thank you very much from my side. Thank you.
Thank you so much, sir. Thank you for explaining all. Esteemed guests, HISP Asia and organizer of this event, HISP Vietnam. It's an honor to be surrounded by such professionals on such platform. I would start by thanking HISP Asia for providing us an opportunity to share the DHIS implementation status in Pakistan. So here is the outline of my presentation. I'll give you the insight of provincial and regional status of DHIS2 implementation, as well as the vertical systems on DHIS2 platform, which includes a nutrition program, emergency, rain and flood management system, and sick and newborn care. On the other hand, we have a tuberculosis program which uses a DHIS2 platform and is managed by a common management unit. With starting my presentation, I would like to explain that we have 4 provinces along with 2 regions, and in these regions, HMIS is supported by HIS Pakistan. Pakistan has demonstrated a substantial expertise in implementation of DHIS2 as a health management information system across all the provinces. Moving towards Punjab, Punjab is one of the largest provinces of Pakistan, where 52% of the Pakistan's population resides, and it has rolled out DHIS2 in all the 36 districts. So it is currently fully operational in Punjab. The frequency of reporting is on daily, monthly, as well as on quarterly basis. And with moving forward, they have launched the Punjab government has launched the health facility module, which is basically developed by the University of Oslo and is customized by HIS Pakistan. This module is basically used for the assessment of health facilities, and recently 2 trainings were conducted in the 2 districts of Punjab, that is Mandi Bahauddin and Jhelum. Here are the few glimpses of the recent activities that were held in Punjab. Moving forward with Khyber Pakhtunkhwa, the other federation of Pakistan, it had, with the fast pace, after January, they have rolled out the DHIS2 in more than 12 districts, and in total 16 districts out of 37. Currently, DHIS2 is operational in 16 districts, and we are having reporting in 16. Their frequency is the same as the Punjab, on daily basis, monthly, and on the quarterly basis. Recently, the first quarterly review meeting was held, which focused on reporting the mechanism and data quality in the pilot districts. But before that, prior to this meeting, field visits were conducted to review the challenges that are being faced on the grassroots level. And their future plan is to implement DHIS2 in the remaining districts tentatively by June 2025. They are also focusing on improving the data quality and compliance. Here are a few glimpses of the recent activities which I have explained. The launch of rollout of DHIS2 HMIS in KP, the inaugural day of DHIS2 trainings, which are cascade trainings. KPK DHISL visit for comprehensive 2-day trainings, where they have discussed issues with the HIS Pakistan related to the software or to the field, as well as the first provincial quarterly review meeting on DHIS2 implementation in KP. Moving forward with Balochistan, Balochistan is one of the largest provinces of Pakistan in terms of area, with a scattered population, and they have rolled out DHIS2 in the 14 districts out of 36. Their frequency is not same as the other federations, reason being they are also biannually reporting, and that is for the financial aspect. They cover their financial aspects in the biannual report. They have currently trained, and the DHIS2 has started reporting on 569 health facilities, and the number of health workers trained are 1836. Their future plan is very optimistic, and they about the future potential of DHIS2, and they have shown willingness to roll out in the remaining districts. They have also planned integration like programs with programs like TB, HIV, malaria, and nutrition, etc. Here are a few glimpses of the recent activities of Balochistan. Launch of DHIS2 based HMIS in Balochistan, 5 days training of trainers on Balochistan HMIS, core committee meeting for HMIS Balochistan, and trickle-down trainings. Moving forward to Sindh, Sindh is somehow lacking behind, but they are still in the planning phase, but they have finalized their reporting tools for the primary healthcare and secondary healthcare, and these tools were also developed by HIS Pakistan through mutual collaboration with the Department of Health Sindh. They have initially planned to implement DHIS2 in the 5 districts by the end of 2024, and the HIS Pakistan has assigned a DHIS2 implementer and a project manager who will support them in the routine implementation of and customization. Their future plan is to implement DHIS2 in the entire Sindh. Here are the few glimpses of activities that were held. First technical working group, TWG meeting, in which they have finalized reporting tools and key aspects of DHIS2 implementation. And on the other side is the second technical working group, TWG meeting, which were newly recommended indicators were discussed and finalized to be incorporated in the reporting tools. And moving towards the regions, Azad Kashmir and Gilgit-Baltistan, they have conducted TWGs where reporting tools are discussed, evaluated, and finalized. Based on these tools, HMIS has been designed, and developed by DHIS2. Their future plan is to start the TOTs in the coming months, and both these regions are planning to roll out DHIS in the 5 districts by 2025. Here are a few glimpses of the Azad Jammu Kashmir and GB. And on the other hand, we have 3 programs or 3 systems, vertical systems, that are currently reporting on DHIS2. One is the nutrition aggregate system, which is a digital data package. It is a digital data package developed in partnership with UNICEF, which is aligned with their guidelines, and it reports and it is used to measure the vitamin A supplementation and maternal nutrition growth monitoring. Sorry, sir. Okay. Sorry. Should I wait? Okay, so the nutrition aggregate system NUT is a digital database package developed in partnership with the UNICEF, which aims to manage nutrition related data within the DHIS2 platform. It is aligned with the UNICEF guidelines. The package is aligned with the DHIS Community Information System, CHIS, which enhance communities level data collection and analysis. Later on, it customizes the data according to the local context. Indicators used in this program are vitamin A supplementation, maternal nutrition, growth monitoring and infant and young child feeding. The second system is the emergency rain and flood management system on DHIS2 platform, which is a combination of tracker and aggregate based reporting. The key elements covered in tracker and aggregate are, in the tracker we have flood casualty program, flood medical camps information program, pregnant women in camps program, health facility flood damage program, and in aggregate system we have infrastructure damages, availability of life-saving drugs, number of fogging machine available, and number of fogging rounds conducted. The third system is collaboration of HISP and UNICEF and Government of Pakistan, and they have piloted an online M&E module for small and sick newborn care. The module is basically a case-based enabling detailed tracking facility and reporting of newborn care. The pilot has been implemented in the 7 facilities across Pakistan, and their frequency is structured on daily basis. Now I'll request Mr. Fahad Hafiz to give you insight of the Common Management Unit. Thank you.
Thank you. Thank you so much. I'll just try to quickly move through. So we at Common Management Unit at Ministry of Health Services Regulation and Coordination at federal level, we are responsible for tuberculosis, AIDS and malaria response in the country. This is a newly department established in 2018. As per Constitution, the federal mandate is to prepare proposals, liaison with provinces, international agencies, technical and material resources to provinces, policy, strategy, guidance, disease surveillance and research, public sector personnel, principal recipients for the Global Fund grant. So as we are looking after the surveillance systems for AIDS, TB and malaria in the country, our initial focus was to have an integrated DHIS2 for these 3 diseases, which we started in 2018. And we started with the aggregate instance for the 3 diseases in the whole country. So this was launched in 2018. And with that, we moved to tracker for tuberculosis. That was done in 2022 recently, with focus on more than 1,500 public health facilities and 5,000 plus GPs, which is also increasing day by day. So for malaria, we have DHIS2 rolled out in more than 5,000 health facilities as well. For HIV, we have a national surveillance system which is linked to DHIS2. where the aggregate reports are recorded on monthly basis. So this is a general overview that the reporting line starts from the health facility to district and then the provincial programs towards the national program. All the data in aggregate goes into the central data surveillance. And for case-based, we have HIV and tuberculosis that is routed through the central surveillance system for reporting to the global reporting and the national reporting as well. So we have been using DHIS2 since 2018 for aggregate reporting with WHO standard packages. Now, since last year, we are focusing on tuberculosis and the tracker that is there and making it available for public and private sector. And we are focusing on making it available for use by the stakeholders and partners. So a brief of the journey I'll just go through. We started in 2018 with the aggregate, as I talked earlier. And then it took us a couple of time. We did some pilots in the tracker because it was required. We cannot go to a rollout of the whole country without doing some major pilots. So that was carried out in 2019 and 2020, where we were, in 2021, where we were able to do it in mandatory case notification projects like MDR-TV. We focused on the tracker. We piloted in federal capital for DSTB. Then the final rollout happened in 2023. So that's our digital journey. This is a current snapshot of where we stand today. In Pakistan, right now we have 99% data completeness in terms of tracker case-based that we are talking about. So 587 users were trained and 21 DHIS2 trainings throughout the country at the health facility level with more than 50% per badges were conducted. And we are at 99% completeness rate. So now what we are working on is a reporting and analysis and use of this data. For the tracker data that we have, we want to use this information for over future interventions. So a glimpse of the dashboard, if you see over here, we have integrated dashboards on the left side. You can see HCV and malaria dashboards are there. We have the maps available as well. We have the case-based dashboards in the country. We can monitor the performance on daily basis, on a weekly basis. Thanks to DHIS Pakistan, this has all been made possible with their technical support and with the support of the partners. So there's another dashboard showing the users reporting by months because we were interested in knowing, are the users using the system? That's very important because just giving them the logins and asking them to enter the data is not important. We need to monitor what is their pattern of entering. So, so the challenges for the next 2 years is transition to paperless recording. We are talking about surveillance systems. We are talking about, we have so much done in the past couple of years, but we want to make sure that we remove that paper system in the country. So this is going to be a challenge for us, but we'll try in the next 2 years that we complete this in the moment. Central organization unit management for the whole country. So as my colleagues earlier stated, that this is a country that has devolved a system, but every province is like a country. So it's a nightmare to manage such users, but we have used APIs of DHIS2 for making sure that the DHIS2 user management is done in a proper way. Same goes for the organization unit management. And another challenge is integration with existing systems in the country for flow of information of a single platform. So we have many provinces, some have their own trackers, their own custom systems. The challenge is to integrate those with the DHIS2. That's where we need to focus on moving forward. And also the last part is the staff turnover and data completeness and validation. So these two challenges remain, whatever system we use and whatever information system we have, either it's DHIS2 or it's a custom system, because in government settings, we have staff turnover. We will have data completeness and validation issues. So we need to overcome with consistency. So on that note, I'll try to close out. Thank you so much.
Thank you very much for sharing this rich experience. And just for the time issue, We will make the only question at the end of the session. Now we will ask Sri Lanka team to present and share their experience for 15 minutes, please. I think, yeah. You can this one.
Right. Good morning, everyone. So I'll describe the DHIS2 implements in Sri Lanka, focusing on the recent implementation. So I'm Pramil Nage, representing Ministry of Health. So brief outline of what we have been doing. So we started in 2009 with capacity building, and then moved on to small scale implementations, then large scale, and then advanced, and now we are moving on to more innovative and major interventions. Right. So what are the areas we cover in Sri Lanka? So basically in the health side, we cover almost all the areas, especially in RM and CHIH. All the modules have been completed, then in surveillance and also in facility surveys. But we have not limited to health domain, so which I have already presented in past 2 sessions. So we have used DHIS2 in education sector and also in climate health, which I will not repeat in this session. And few big instances we have launched DHIS2. So one is the electronic reproductive health management information system, where we capture all the aggregate information related to reproductive health. And these was initiated in 2017, the largest, actually you can call it the largest island-wide implementation. And so many presentations have been done on this, and so many awards have been received by this. So because of the time constraints, I won't be going into all the details. But then we have extended that reproductive health management system into phase 2 to capture the individual level information. So this is also implemented in both private and public health sector, where we capture details about individual deliveries, then maternal and neonatal deaths, then newborn screening, COVID-19 pregnancy vaccination, nutrition assessment. So this is also being successfully implemented and continuously now happening in Sri Lanka over a long time. Then in the COVID era, we had 2 major interventions, again discussed in a lot of forums, and I think you have already come across. So one is the surveillance platform, where Sri Lanka was the first country to respond with a digital solution for COVID-19, especially for port screening and patient surveillance. And this metadata package was reused by University of Oslo, and they distributed it, and it was reused by a lot of countries. This module contained 13 modules related to COVID-19 surveillance, and this was followed up by the immunization tracker for COVID. Again, we used this to generate the smart vaccination card for COVID-19, and this was also used by a lot of other countries after being recognized by the HIS community. Then this is one of the first mobile-based interventions in Sri Lanka using DHIS2, the district nutrition monitoring system, where we registered children with malnutrition at the field level and monitored their risk factors and also the nutritional status with their location, and also used analytics in the mobile app, which is later developed further, and then again synchronized with the central server for analysis. Then moving on to communicable diseases, DHIS2 is used in some of the vertical programs, like for malaria, we are using DHIS2 for case-based surveillance. Obviously, we have eradicated malaria, but we still continue surveillance. And then parasitological and entomological surveillance and control. And for immunization, we have the electronic national immunization program system where we capture immunization, aggregate reporting basically from public health institutions at field level, and then the AE5 reporting. So both this system data is captured using DHIS2. And for leprosy, we have a case-based management system. So all the patients in Sri Lanka having leprosy is tracked in this system. We are enhancing this disease surveillance component in Sri Lanka using DHIS2. So currently, as you have seen, there are a lot of things happening, but vertically. So we are planning for an integrated approach, especially with the epidemiology unit, then the Family Health Bureau, which runs the ERHMIS, and also the vertical disease program. So currently we have initiated this intervention because most of the immunization record is also captured in ERHMIS and also from the epidemiology unit. So we are strengthening the epidemiology unit instance to capture immunization, then supplementary immunization activities planned, especially for measles, then the A5 reporting, vaccine stock management, then disease surveillance for other diseases, and case investigations for notifiable diseases for individual cases, and then to strengthen for public health emergencies, especially for this monkeypox. We are ready to use DHIS2, but now it's not a big threat at the moment. So if that becomes elevated, then we will be responding using these systems. And also the vertical disease program will be also integrated with this system so that whole disease surveillance will be taking one approach. So already we have started with the weekly epidemiological diseases return and investigation of communicable diseases, and also vaccine stock information and AE5 already being developed in an integrated approach. Right. So this is another new intervention we have implemented. So this is a good example of collaboration through of various institutions and also integration of various technologies. So two aspects which we have been successfully implemented. So this is, in this implementation, Ministry of Health, the Sri Lanka College of Endocrinologists, and HIS Sri Lanka in collaboration has implemented this. So what this does is, it screens diabetes and hypertension from the community using these mobile apps. So there's a community screening app, and also from the clinic, once they are referred, there's another app used. So both these use OpenSRP technology. Then also we have an existing system in healthy lifestyle clinics for diabetes and hypertension. So that system is also integrated. So all these are integrated through Fire Gateway and through a Fire server and connected to a Postgres data base. And then finally, the data is passed to DHIS2 for data analysis, then decision making. So this has been successfully implemented in one district, and it is being expanded. So a good example of integration and collaboration. Then for non-communicable diseases also, we are using for mental health clinic return, and also for injury surveillance from all the hospitals. DHIS2 has been used now over 5 or 6 years. And we are developing a system for patient care, quality and safety. So that is also being used, implemented, will be on DHIS2. And another system for laboratory management information. So this is not LIS, this is like monitoring the indicators of related to laboratory services provided. So this is also being now discussed and being developed. So this will be available. And we are aligning with the recently developed National Digital health blueprint. So a complex diagram, but I've focused on one area of this on the secondary data use. So this is where we are planning to use DHIS2 mostly, apart from the already implemented solution. So there will be like a digital health information warehouse, and DHIS2 will be a major component of that, and it will be used for data analysis, research, the planning and policy development purposes, dashboard. So all these components, DHIS2 will be a facilitator. Then how are we doing this? So many stakeholders involved. So these are the main stakeholders. As I mentioned, we started with capacity building with our master's and MD program in health informatics. And this was supported by University of Oslo, then University of Colombo, and postgraduate of Institute of Medicine. So we built a good team with DHIS2 capacity, not only DHIS2, but DHIS2 was a big part of those curriculums. And then we got support from University of Oslo through academies and other trainings, and then Ministry of Health. So we get on-the-job training from Ministry of Health. Once these people go for the jobs in Ministry of Health, we get exposed to different DHIS2 projects, and then build our capacity. And HISP Sri Lanka is supporting all these projects through capacity building and expertise. So most of these instances, we have a support model, where a 3-tier support model with a help desk and general technical team, mainly from the Ministry of Health, and specialized assistance from HISP and other special technical experts. And to support that, we have also developed a local community of practice with the DHIS2 experts and all the people who are implementing DHIS2 projects. So this is like a knowledge sharing platform where Ministry of Health is coordinating, and there's multiple channels of communication. And through this community of practice, we have improved the capacity, then a lot of collaboration was improved, and also the instances and all the implementations has become more stable with all the support. And also the interest in DHIS2. So whenever people come up with ideas, they think whether DHIS2 is also possible to be used. You must have seen a lot of interventions, and most of these are vertical. So that was due to a lot of reasons, a lot of administrative issues, then logical issues. So we are trying now to integrate all these systems, especially for decision-making level. So we have proposed this integrated public health information system architecture, so to get all the data for decision-making from all these vertical programs, and like which to facilitate the digital health blueprint which I showed. So this is also in discussion now, and will be like a part of the digital health architecture in Sri Lanka very soon. So what is our final goal? So we want to promote DHIS2. I want to highlight the word appropriate here, because that is more important. So appropriate use of DHIS2 within our digital health ecosystem, and also to build the capacity of the country, and then institutionalize this system so that the people in the Ministry of Health can take responsibility of these systems and run these systems to make it more sustainable. So finally, I think most of you have visited Sri Lanka last year for the Asia Academy, and I know they will be willing to visit again. And those who have not visited, I plead you to put this into your bucket list on the top, so that we can see you in Sri Lanka very soon in this nice country. Thank you.
Thank you very much for sharing this inspiring experience. Now we will invite Palestine to show their experience in large-scale implementation and other systems. Please.
see if there are any questions for the first two presentations. Pakistan, Sri Lanka.
Is there any question for about Pakistan and Sri Lanka? Maybe just one or two questions if there. Yeah. Okay.
Thank you. It's a very good presentation. I think there's a lot for us developing countries to learn from, especially in the Pacific. My question will be, I think in terms of the costing, it must cost a lot in terms of bringing all this system in place. So do you have a clear, maybe you can give a rough estimate on how the cost would be like? It's to any of the two countries.
Maybe Adnan will reflect on it.
I mean, it depends upon country to country and the amount of implementation you are doing, because it's not one cost fits for all, but you have to basically analyze. So before you go into implementation, you have to make technical working groups. You have to analyze everything that what costing will be there involved. You have to identify the partners who are willing to support you. Like in Pakistan, we have UNICEF, we have World Bank, we have Gates Foundation supporting. So then the budgeting is done, that how much you need capacity building, how much health facilities you need to cover, how much equipment is required, how much configuration is to be required, how much customization you need to do. So there are a lot of factors involved. But I guess you need to have multiple consultative meetings with all the partners, and then you can basically understand. Yeah.
Let me highlight a slightly different perspective. In Sri Lanka, it is quite different. There is a lot of government buying in, and one main thing Dr. Pramil highlighted was the capacity building, because we wanted less dependency from partners. So, I mean, I'm representing HIS Sri Lanka and Dr. Pramil is representing the ministry. So the thing is, that capacity building program that started in 2009, where you had the government university building capacity for the Ministry of Health. So there's on-the-job training. So with that, you have Ministry of Health staff at national and sub-national level who knows the systems. It's not DHIS2 only. We have many other systems, many more digital public goods where they build capacity. So that ways, they keep on building capacity in other health staff categories. So that's a major component. And plus, there is a lot of government funding that comes in for maintaining these systems. Of course, we get support from all the donors, but we have been significantly able to be less dependent from donor funding due to this government buying in. So we kind of see like different perspectives from different countries.
Maybe one question only, if there is. Yeah.
Yes, I am echoing the Pamos speech. In Bangladesh, you know, the Bangladesh is one of the largest implementation. But gradually we're handing over to the government. So government now taking care of the hardware, the capacity building, yearly capacity building. So all is coming from the government revenue budget. So it is already budgeted for next few years. So the system will run properly. But a few technical core areas, HIS Bangladesh is supporting. And mostly this is coming from the donor funding for UNICEF, Asian Development Bank, World Bank. But this is not much significant amount of money. But initial, when we started in 2010, this initial thrust was external. That was done by the GIZ, which is around 3 million USD for the whole country implementation initial. Then is a go program by total by the government itself. So now there is a, from the government budget is spending, so it's gradually reducing down.
Okay, now let's move to see Palestine experience. Please, Yusuf.
Hello all, I'm Yusuf from Palestine, Minister of Health, Cork team. That's a brief about Palestine, small brief. Palestine divided to the 19 health districts in Palestine, 14 in West Bank, and 5 health districts in Gaza. but our population is a small country, about 6 million, 3.5 in West Bank, 2.5 in Gaza. Total land are 27,000 kilometers. West Bank 5,500. Gaza 365 kilometers. We start DHIS from 2060. The first tracker system is MCH e-registry. In 2070, we scale up the team and create DHIS core team. In 2090, DHIS scale up and start with the tracker system like RTA, mammogram, NCDs, and etc. 2020, as you know, COVID pandemic, and we create surveillance and publish data to MOH site. 2001, we implement the family health record and registration. And we start pilot in 4 districts of 14 districts. 14 districts because West Bank, because all districts in West Bank and we don't have access to Gaza or other. In 2030, implementation 15% of district in West Bank. This data set for our program, how we started. بس في جدول مش مبين. الجدول مش مبين. ايش؟ There is a table. Minimize. There is a table. Table on. Okay. In 2070, the tracker system was one, MCH e-registry. This is the first tracker. This is the first e-registry system in the DHIS, and we have 9 aggregated system. Now, in 2024, we have 31 tracker, 28 event, and 29 aggregated. First day, digitalized process has considered the MOH property. We have 380 clinic are using MCH e-registry. 88 clinic use electron family health, especially in Selfit, Tubas, Jericho, and Bethlehem. This is a district in Palestine. Use a child, NCD, GB, and special visit, lab, drugs, immunization tracker. 14 districts are using HMIS, routine statistics, aggregated system. 100% are using case-based surveillance system. 14 districts are using mammogram. 14 is covered all the West Bank district. 14 district has all using digital health. 14 district using case-based surveillance and gender-based violence (GBU). 14 district using RTA. 14 district are using health education. 14 district use CRVS tracking. This is some number. until end of 2030. We have a tracker instance entries 100, 140, and MCH we have 295, and family health we has 195 record. Talk about MCH. MCH is a maternal child health care. This is the first project, first e-registry system on the DHIS. The program has been successfully rolled out in 38 clinics across the country, out of total 38. And currently we support over 2,000 active users. Family health program. This is the biggest one program, tracker program. It's like EMR, but not the same. You know, we can talk it unified record. Start from registry, family health file, then child program, immunization, pharmacy, library, radiology, accounting, and bin approach. Before family health, we have separate program and separate tracker. Then we calculated in one instance, in one program. Our future plan is to migration with MCH and family health, and integration with the insurance and MOI system, and then lab device integration, stock management module, and finance module. Our challenges, as you know, for finance and budget, team formulation and governance, requirement management, stakeholder involvement, interviewation, change management, change request management, and communication, technical support. Thank you.
Thank you very much, Yusuf. All eyes on Gaza, for sure. Is there any question before moving to see Bangladesh experience? If no question, so okay. Hannan, please, to present Bangladesh experience.
Thank you, Mohammed. So, good morning. I'm in front of you again to present with the Bangladesh case. First, I apologize because our government counterpart cannot make it to join this conference because of there is a political change in Bangladesh, and due to that, they can't give the government order to leave country. So I have to present on behalf of them. So first I show you the same thing. Every year I show the same thing, but it's not the same. So if you see, there is something changed. On my right-hand side is the Minister of Health. On my left-hand side is the Minister of Urban and Private. So you see the Minister of Health, the green boxes are all is done. And on the left-hand side, we just complete one urban health project, which is covering the significant part of the urban health area. So among these, there is some few achievements. For example, we achieved already Kalajor, the vascular espanthiasis. This elimination certification, which is we run one of the first successful tracker, where we track every Kalajor patient from scanning to treatment and follow-up. And we achieved the WHO, the Kalajor elimination certificate last year. So this is one of our achievements that we achieve, help government to achieve with DHIS2 to track each patient, treat and eliminate the disease. So similarly, filariasis is also running the elimination phase, and we are also in the process to go for the malaria elimination program. And on the left-hand side, I go gradually everything step by step. So first we start with the reverse direction. So first we go to the Ministry of Local Government. Ministry of Local Government actually is responsible for the urban health, which in the urban area. So urban primary healthcare part is taken care of under Ministry of Local Government. So here what we project working on is from 546 clinics over in 11 city corporation. You know that we have in the whole Bangladesh, we have 12 city corporation. We actually, the plan have 12 city corporation, but one mayor doesn't want to implement the health information system. So we have to go with the 11 out of 12, and for 18 municipalities. There's divided by 45 project areas. So there is comprehensive reproductive health care center, city maternity hospital, 157 healthcare center, and 334 satellite clinics. So what is the significance? This is a tracker-based system. So every service is provided to DHIS2 tracker at the point of care. So who providing the service, he is entering the data. So there is no other person there for entering the data. So actually this is not use of any paper. They just do on the tab or PC. So there is no need of data entry operator. Nowadays, you don't find any data entry operator in any ministry. So that's the objective. And second step, at the end of month, automatically internal ADX has been done. So aggregate data exchange, this actually from program indicator go to aggregate monthly data, and which is approved by the head of institute or head of facility. And then this ready for the quarterly report, which is every quarter produced automatically and go through the Asian Development Bank financial reporting, which is around 60-page report. So there's total 161-page report. Among that, 60 pages from our data. So what kind of report? Including financial, how much patient they see, how much subsidy they provided, how much income they have. This is subsidized clinic and free also. So that's also calculated automatically. And linking data with the money is a good significance. The data quality is very good. So when we implement the system, there is some change in data. So we can very easily see what's the difference. Say for example, earlier the delivery number of delivery the showing is less. The cesarean section was less. Now it's changing. Why? Because if there's a Caesar, they have additional money. So linking this with the money is actually improved. So and this actually is a few pictures of the field where they're entering the data. You see? Even on the river side. So these are the clinics. These are satellite clinics. So from there, and we use the DHIS2 Android as an offline tools to use the data entry at the point of care. And what we do, we feed the data to the web portal. So the people can see their data publicly. So this is aggregate data viewable for public viewing. So if the data quality is not good, you will not give any data to the public. So that is one example, but this is not a static portal. So you have the dashboard menu where you can do your customized requirement. So you can have your own query and any chart, any graph you can see as per your requirement. But now look at this is one of the report which is going to Asian Development Bank, but I try to make several pages together. This is online. Also, what they do, they download it and put it with their main reporting in the MS. They actually do in MS Word. So we download in Excel and export it to the MS Word. So the 60 pages automatically made, and they are just actually put the reporting format and printed every month, because the rule is they have to print. But if you see the data, this is the last quarter data. Maybe you cannot read at all. This is the resolution. But this is last 3 months, April, May, June. The total new client is 198,000. Total new client. Total service provided in that month is 2.6 million. Total service, 2.6 million last 3 months. And total, after cumulative service we provided in that specific system is 45.6 million services. So imagine the scale. So this is example. This is publicly available dashboard. So you can see by yourself. I will share the link later on so that you can see. Now move to Ministry of Health. You know, the Ministry of Scale is also, Bangladesh is a very small country, but only 55,000 square kilometer, 1/10 of the Norway, but it has people of 180 million officially. Unofficially, a little more, maybe 19 million. But you know, the Norway has only 50 million, if I am correct. So you see, 5 million. Oh, sorry. So in Dhaka city only we have 35 million. Dhaka city only. So that's the scale. The idea is when we design any DHIS2 tracker, we should be very, very careful about the scale, how we would go. And the data entry point, we have considered the many things. So let's move forward. So we are not only collecting data, we are also using the data. This is quite a few examples we are providing here. So we have the HSS scoring module, which is based on the WHO building block, which by WHO. So WHO actually requested to do this. So from every month's routine data, not only HMIS, also HRIS, logistics, everything fit in here to making the scoring of the facility. So what facility did? So we score which facility is scoring 1 to 10, every type of facility. So there is a competition among the facility for data entry and quality of the service. So not only data, we have also the survey. So there is a on-site survey. Someone visited with the DHIS2 Android and make the survey questions. There's a grievance system that's also adding in the scoring. So this is one example how we facilitate. And this built on, some part is built on DHIS2, some part is not. So it's actually providing to the portal. All is, HSS is in portal. Second part is in monthly meeting decision entry and follow-up. So there is every month, there is a hospital management committee meeting. That's also feed into DHIS2 so that the upper level, the centrally they know which hospital management committee meeting, what decision was made and what the decision follow-up is. So if there is a hospital, say someone said that there is a toilet and other is unclean, so they have to clean it properly or not, whether it is follow-up. So there is several decisions they have to feed and write in the DHIS2. So centrally, they can monitor what the complaint was, what was the management decision was. So hospital management committee meeting, this also. Similar, we have the community clinic, several meetings is also in the DHIS2. So meeting recommendations and meeting minutes is also in the DHIS2. So they have to follow the management, not only service data as well. Another part is DLI, or Disbursement Linked Indicator. You know, the World Bank Sector Program, they separated $800 million for the DLI. So certain DLI achieved, and out of 14, 8 DLI from the DHIS2. So from DHIS2 data, if they are measured, they took quarterly report and go to the field. And they took the paper report, they took a username password from us, from the government, and go to the field, verify the data, go to the client and ask whether he or she is having this service or not. So randomly verify the data and approved the DLI. If that was achieved, then government gave certain amount of money. So that's actually improving the service. But the point is, from DHIS2, we support this activity. So they are not depending on the third party. They are doing by themselves. So new thing we added is the IMCI tracker. We know the IMCI mostly we put as aggregate data collection. But IMCI we are introducing as a outdoor service for common childhood disease. This service provided includes our symptoms. So this is a sort of decision support system. So they just click on several symptoms. Say, for example, how the rhythm, how the breathing for 1 minute, how many times is breathe, what is the wheezing, is there any wheezing or not. He just puts yes or no. The decision will be made through our program rules. So through the program rules, we make the decision. Like e-register in Palestine, we also have e-register in Bangladesh, we also piloted. Similar way, we make the algorithm for these yes-no questions and decide, they automatically assign the diagnosis and danger level. So there is a overriding system. Override, he can override, but he has to explain why it's override. The system automatically generates aggregate data at the end of month from this tracker. So this is also, we are moving forward from aggregate data to the tracker to make the system automate to have the decision support system. Similar for SCANU tracker. So SCANU tracker is also new. The SCANU is registered with the patient ID and the address in the newborn ID. Because the newborn in my country doesn't get ID immediately, because the newborn name usually settled within 2 weeks, not when his birth. So that's a problem. So we always name as the mother's name with the son or daughter of mother's name, this way. And newborn assessment, there is done in the SCANU tracker. This is also same, decision support system. So they have to some use the question, and this system make the decision. He can override the decision, but the important point is if this baby need follow-up, this community follow-up actually push to that specific location. Now our some area we are using piloting the OpenSRP. So we are throwing this, push this patient to OpenSRP. So look, this patient is going in the area, so you have to look up this specific child. So that is one way we are doing. So OpenSRP and those hospital has Open MRS. We are also working on that, and hopefully by October we will also integrate with Open MRS. So SCANU tracker feature I already told, but this actually the screen is look like that, but I think due to resolution you cannot see much. I cannot see even. So there is also the notification, provide service provider to call mother. So there is a SMS notification going to the service provider so that he or she can follow up her in the community as well. So another area is the NCD. So NCD cancer tracking, where we use the cervical and breast cancer follow-up. So cervical and breast cancer in DHIS2 tracker in 43 districts, 441 sub-district, 8,000 community clinics are already implemented. So there is several stages. So not only screening, there is a community registration, bias screening, visual inspection through acetic acid, clinical breast examination screening, colposcopy screening. This is a step-by-step. So one woman in one sitting, we include the cervical cancer and breast CBE screening, Y and CBE, because usually we cannot get him twice. So when we get one chance, we're screening both. Similarly, many places we link with the gynecology department. So if every woman within the 30 to 60 year range is there, we can go for the mandatory cervical cancer screening. And that actually helps a lot. And next stage is colposcopy screening and breast screening, where we use the mammography and MRI, where it's available. Then if it's positive, then go for biopsy and cancer staging and cancer management. We're working with the WHO cancer team in France to finalize the protocol with the cancer specialist. We have the several consultation. So we have the cancer staging and cancer management we also already implemented. So this is in progress, because now only 4 hospitals. So yeah, 3 public hospitals and 1 private hospital is using the cancer treatment. So we have several other cancer hospitals, so gradually move forward to others. But the issue is we need for the cancer treatment, we need some specialized equipment which they don't have. So government are going to procure those. But this is within the government system, so government can rolling out by themselves, not by his. So he's only now providing very core support, very small support, mostly run by the government. So NCD, that NCD also has a public dashboard where we can have this type of chart, where the same, there's an automatic chart, and you have your customized one. So you can generate what you need from this dashboard. This is also publicly available. So you cannot have any tracker or personalized data. You can have no aggregate data for analysis. But is this aggregate data actually generated from the trackers? So those also we are providing the GIS mapping as well. Another NCD we have is hypertension and diabetes mellitus. So hypertension, half of the country already scaled up. The issue is the hypertension and diabetes is we can roll out whole country, but the problem is we need two things. First is to measure the hypertension. You need the blood pressure machine, and the people know how to measure blood pressure properly. And second thing, we need the diabetic glucometer so that they can identify the glucometer strip and everything. And also, if he's identified as a diabetic or as a hypertensive, then you have to provide the medicine. So this logistics, the associated logistics is required. So government actually moving slowly because when they can provide the supporting logistics. You see, so they have to monitor this way. So how much the cumulative patient and how much the new patient and control rate. You see the control rate is high. That was good, performing well. And the missed visit. So missed visit is also important. Who are missing the visit, so we have to alert the patients to come up. So thank you, everyone. This is from my side. Questions?
This is a thank you in all language. Thank you, Hannan. Okay, is there any question for Bangladesh experience? Okay, any question? This is another exercise.
I think I'm making you run every time. Hanan, thanks a lot. I can see there is a tremendous progress working with the Asian Development Bank on urban health. And finally, after 10 years, I can see the Scano has really progressed, was not behind. I have still the question which puzzles me. DHIS2 was mainly driven by the Directorate of Health Services and Department or Directorate of Family Planning. They had their own system.
Right.
So, and we tried to unify these two giant departments together, and government is not here. And it was not successful. So implementation at the community level, community clinics, DHIS2 was the first approach to unify this scattered health management information system in Bangladesh. So
yes.
My question is, how you managed to bring family planning and all public health into one architecture of a health information system?
Yes, thank you. Yes, you are rightly point out the challenge. So since when you are in Bangladesh, so we jointly try to converge everyone to one single system. And our Ministry of Health and Ministry of Local Government, even inside the ministry, the Director General of Health and Director General of Family Planning agreed to use the single platform, agreed. But last year, our minister officially said that no, there will be no unification, there is a more dividation. So means the DZ Health already broken into two. So one is the health services and one is the health medical education. So there's instead of unification, they are going for the more dividation. So we have to find a way out. So what we agreed that now in digital health policy, we put that all is shared with the single health ID. And we will make a shared health record repository where everyone can send record. so where everyone can pull records. So that is decided. But you know, due to this bureaucratic process, this takes time. So when we implement the urban health, so that's in the last line, the patient referral with the Minister of Health hospital done in the next phase. Why? Because when we implement, they are not agreed to give us the health ID to the Ministry of Local Government. Because the secretary said, I'm not approved it yet, so you cannot use that. So we have to use our separate ID system. So now what's the plan is, in next phase, which is supposed to be start in 2025. So that time they all record with our single health ID and record pushed to the shared health record. And this patient, if you go to another hospital or another clinic of the DG Health, they can pull that record and the continuum of care can be done. So this will be done in those hospital has automation in OpenMRS. Those hospital has DHIS2. So we have to revise the all DHIS2 with the shared health record. So we have the limitation earlier, but you see the last day our Oslo teams showed that we have now a plugin where we can have called API externally and the health ID. That's actually the thing we are waiting for long. So finally it is there. So we try to use this one and we try with the urban, we are just trying with this an urban project. If it successfully can be done, can we replicate to the DG Health as well? So that is one way. And family planning partially using the DHIS2, and we are still pursuing them so that they can have the DHIS2 tracker. You know that they use the different tracker. So that's difficult because that is not standard. They're using the shared health record and other standard. So we have a discussion earlier, but due to the government change, we have to restart the discussion with the family planning again. Thank you, Shukrat, for your question.
Okay, thank you very much. Now we will just present the last, before last experience, Vietnam. The last one, please. Vietnam experience. Let us move the slides.
Hi everyone, so I would like to share our experience in our DHIS2 for NCD management in Vietnam. So this is the NCD status of Vietnamese people. So you can see that about 30% of people in Vietnam with NCD, like hypertension, diabetes, cancer, and so with the population of 1 million, so it's about 30 million of people with NCD. According to our regulation, so doctor just allowed to give medicine 1 month, maximum 1 month. So that means that a patient had to visit the health facility monthly. So if all the patients get treatment, so the number because increasing very fast. That's why we had to use the software for data management, and we use the DHIS2 for we use for report on general information, for screening and health checkup, and for drug supply. For the event, we use for report on the training for healthcare worker. And for the tracer, we use for hypertension, diabetes, epilepsy, schizophrenia, depression, anxiety, COPD, asthma, and other NCD. But we just, at the moment, we just focus on hypertension and diabetes. So this is general information that primary care, we call community health station, has to report annually. So now they can use this channel to report to higher level until MOS. So this is for screening. You can see that in 2002, this number is hypertension measurement. So about 11 million people in Iran, Vietnam measure blood pressure each year. This is the drug supply. You can see that about more than 1,000 communal health stations in Vietnam use this system to report on drug supply. And the percentage of commune health stations have enough 3 types of medicine according to MOS, about 40%, and for hypertension, for diabetes, just 30%. And this for the training. So by 2023, more than 45,000 healthcare workers are trained on the NCD management, mainly hypertension and diabetes. So this year, cumulative number of people visit all health facility, about nearly 2 million. And this year, cumulative number of commune health stations use our system, 7,600. And the cumulative number of hypertension patients visit commune health station, 1.5 million. This is the cumulative commune health station entered our program by time. So you can see that it increasing. We also follow the number of patients visit commune health station and percentage of blood pressure control. So the total number of patients visit commune health station nearly 600,000, and the percentage control nearly 70%, and it increasing. We also can monitor progress of each patient over time. You can see the same number here is the same patient. So this patient visits a health facility on April, on May, June, July, August, and September. Here is blood pressure. Here is the medicine they are given. So we can monitor whether healthcare worker give a prescription according to MOS or not. So it's very useful. So we also use the DHIS2 to put the guideline material, so it increases the access of healthcare worker to the material. Some challenges. The first, the connection to the software for social health insurance reimbursement, because almost all the health facility in Vietnam sign contract with the social health insurance, so they have used the software to put the data on the system of health insurance. But now when we introduce this system, so healthcare worker had to enter data twice, one for the health insurance system and one for our system. But later we improve by indirect connection through Excel sheet. So healthcare worker can extract the information of patient from software for health insurance to the Excel sheet, and then after that import to our system. So it's reduce manual work, and we also planning to connect directly through API. But at first we just try to connect with software of two big companies in Vietnam. It's VNPT and Viettel. And the second challenge is the huge number of patients. So as I mentioned, in Vietnam we have about 3 million people with NCD, so that the data will increasing very fast. So currently we still have some problem. The system a bit slowly, and we need to overcome that. The third is the health information system in Vietnam is still fragmented. Overall architecture is not that clear, and for DHIS2 had to competitive with the very big IT company such as the VNPT and Viettel. So that's all for my presentation. Thank you.
Okay, thank you. Thank you very much for sharing Vietnam experience. Any question? Okay, if no questions, so we'll go for the lunch now and we'll return back on 1:30. Thank you all.
Hello, hello. Okay. Hi everyone. We already have the good lunch, so now we'd like to continue the session this afternoon. This session today will be the update from development partner, and Pamod will start.
Right. Good afternoon, everyone. So we are slowly coming to the end of our conference, but we kind of kept some of our most interesting sessions to the last. So one of them is the updates from the development partners. So we all know whatever activities we do in most of the countries where we operate, which are developing countries, we need support from many stakeholders, right? So development partners are very crucial in that process. So they provide us support related to advocacy, connecting with between different partners, financial support as well as technical support for the activities we do. So this includes DHIS2 implementations as well. So in this session, what we are trying to do is to get some opinion and ideas, updates from some of the development partners here. I know there are many of you here, but we have selected few of them. So they will give some updates. So there will be a couple of presentations, right? And after that, we are going to open it up so that all of you can ask some questions and get your issues and any queries clarified. So we have roughly a little bit over 1 hour. And then we have 6 people from representing different development partners. And of course, we will start with the University of Oslo. So the purpose of having University of Oslo at the first is because this was another discussion that we had in our big conference that we had in June this year, right? So because this is of so much importance, we discuss how partners can collaborate and work together at mostly at a global level in that conference. And here now we are in the Asia region. We will try to have a sync between the dialogue that we had in Oslo and the discussion that we are having now. So we will start with University of Oslo, and then we have different partners representing so many different organizations giving their updates, and followed by that, there will be a Q&A session. All right. So as the first presenter, let me invite Ulla Tisdelstad, the Deputy Director of University of Oslo. HISP Center, University of Oslo.
Thank you, Pamod, and good afternoon. So first of all, HISP Center at the University of Oslo is not a development partner and by no means a donor, but we work with most of the development partners in global health, and I think we can play a role as a bridge between country governments and these partners, and also I'll have a few requests here and some ideas how we can strengthen that collaboration around how to strengthen health information systems. So what this slide is a little bit of background, what we are seeing happening in many countries, and I think we've, including the country presentations this week, you see that there are a lot of different initiatives with DHIS2, which is great, but sometimes these are happening a bit kind of in isolation, different health programs doing their own thing, another program there, and it's not always well coordinated. Sometimes also pushed by development partners that have very clear kind of program-specific objectives, and they start a new DHIS2 project without integrating with the existing one. So I think this is a little bit of a trend we are seeing, and we have some ideas and tools to help improve coordination and integration. And of course, a core objective of HISP in providing the country support is to support an integrated approach, an integrated health information system where users can access all data in one place in an integrated manner, and one core team, technical team, one technical system can support the needs of multiple programs across the ministry instead of having many fragmented systems. And to some extent, we have also contributed a little bit to the fragmentation through this collaboration with WHO on the health data toolkits. So we have many metadata packages and toolkits describing how you can use DHIS2 for different programs like HIV, TB, malaria, immunization, etc. But the idea is that these toolkits are all designed to fit together in one integrated system. But sometimes they're implemented as separate. So this is the illustration here that white dotted line can mean one integrated system where you can support all these programs in one place. Just like I said, supporting an integrated approach can be highlighted. I think we had a parallel session in the back there yesterday with Sorab. He explained a bit about this maturity profile, the DHIS2 maturity profile, and some of the planning tools linked to that. And if you haven't seen that, I think you can watch the recording from Sorab for more details. But the quick summary is that that assessment gives a holistic view on the DHIS2 system in the country, talking about the quality of the implementation at aggregate level, tracker level, and also this kind of cross-cutting foundational level, like the server support, the security, the human capacity in that core team, etc. And then the HISP groups working together with governments can write recommendations, executive summaries, inputs to planning. And the idea here is to really have one holistic plan, one plan for DHIS2 strengthening in the country, that governments can then take to development partners and support a more coordinated approach to investing. Instead of investing in multiple DHIS systems, maybe training different teams, try to have a coordinated way to have one technical team, one system, one server, etc., that can be supported jointly by multiple partners. And I think that's really the recommendation from us. The request here is to encourage development partners to work together with the government, together with the HISP group, around this one holistic plan for DHIS2. And we work a lot with the same development partners at global level in what we call the DHIS2 investor group. And we know that there is commitment to have this kind of coordinated approach to support one DHIS plan instead of many. But I think the work has to happen in country. And very often the country offices of these partners not always coordinated well with the global. And of course, in each country, you have projects with specific objectives that can be more challenging to align in practice than this kind of more theoretical exercise at the global level when we talk to partners. But you can see all the partners here that we are engaging with. We had a big in-person meeting in Oslo in June, as Pamod said. And then we've had many follow-up calls now, trying to look at what are the mechanisms that can be in place in countries to support such an integrated approach and more coordination. And it'll be exciting to hear the other partners here today talk about what they can do to help strengthen this coordinated approach. So I think this is a bit of a encouragement both to the country governments as well as the HISP groups supporting the countries to really take that maturity profile, those results, that plan, and try to promote it to all the partners. Be transparent about, what is the progress, what are the different investments, and be very clear on where you want to go with DHIS2 in your country. Have a clear roadmap and kind of strong governance around it. Then I think the chances of having that coordinated investment is much, much bigger. And many countries have these technical working groups with development partners in country. I think that's an excellent place to come with that plan and the progress updates on the DHIS2 maturity. Yeah. So I just wanted to, I have one slide also, because this is a question we very often get, is that when you want to work with a HISP group on your DHIS2 strengthening activities, how do you approach them? How do you contract them? And we have some global framework agreements that can help in this case. So, for example, with UNICEF, we have what is called an LTA, long-term agreement, that spans for 5 years, which is also applicable to any UN organization, including any, of course, UNICEF country offices, but it could also be UNDP, WHO, etc. What that means is that if your scope of work falls within the broad kind of DHIS2 strengthening activities that is in the UNICEF LTA, you can approach University of Oslo, and we can set up a contract without kind of a big RFP process, because it falls within the LTA. And we have examples where WHO country offices have also kind of used this LTA as a framework for procuring services then from the HISP group. We have a similar arrangement with CDC, US CDC. They call it a collaborative agreement, or a COAG, which is the same, that CDC country offices can, what they call, buy into the agreement. If they have a specific scope of work with the government and they want HISP group to support them, they can make use of this collaborative agreement to make procurement easier. We also have a slightly new approach this year with the Global Fund. So Global Fund have over many years been supporting countries with DHIS2 TA through various kind of global and regional funding mechanism. That has stopped this funding cycle since the beginning of 2024. Now that TA has to be funded through the country grants from the PR. What we have worked with the Global Fund in Geneva to see how we can make it easier then for the PR in country receiving the country grant to then contract the HISP group to get the DHIS2 support that you want. And we have come up with an approach using something called the third-party disbursement model. So it is a contract between University of Oslo, which is a vetted vendor in the Global Fund system, and the PR, where we outline the scope of work and the budget for deliverables. And then, and Global Fund is not a legal partner in that contract. But when the PR approves a deliverable, they will request the Global Fund to transfer the funds to UIO. And that's hence this third-party disbursement model. But that can also, and many of you have been involved in this ADX, this direct reporting. I think Jason talked about a little bit yesterday. Data quality activities, core team capacity building. Could also be work, of course, on HIV, TB, and malaria, tracker instances or aggregate around data use, all these kind of TA activities where you would like HISP to support you. You could potentially then get it supported through your Global Fund grant using this mechanism. And then, of course, HISP groups in Asia, the 7 groups, have organized in a consortium called the HISP Asia Hub, of course, organizing this event. But they can also then set up agreements with development partners to help coordination, especially when you have multi-country projects in the region. They can provide an easy way to reach many countries, many groups through one arrangement, one contract. And there are some examples. They have one contract with UNFPA, which is a multi-country contract here in Asia and Pacific. They also have an APW with WHO CRO office, the regional office. And I think there are a lot of potential in exploiting this regional coordination. It means you will have a better coordination, better project management, financial management from a kind of a central HISP hub instead of having to contract many different individual groups. So that's something we would really encourage here in the region. And the groups in Africa have organized themselves in the same way in the HISP Africa hub. Okay, I'll stop there, Pamod. Thanks.
Thank you so much, Jula, for sharing the UIO, University of Oslo's perspective and keeping us all informed of the discussions that we had in June at global level. All right. Next, we will move on to a partner organization who have been very instrumental in the entire Asia-Pacific region, which is the World Health Organization. So we will start from country level first. So let me invite Achala Jayatilaka, who are representing the WHO country office, Lao PDR, and also to share us some country perspectives, updates, as well as some aspects possible from the Wipro region.
Thank you, Pramod. Good afternoon, everyone. I will briefly update you about the WHO Laos country office support to implementation of DHIS2. So since 2013, we have been supporting Ministry of Health. At the time, Laos adopted DHIS2 for National Health Management Information System. We are strongly supporting the Ministry of Health, and we are working very close collaboration with his Vietnam team. So let me start. We are supporting so many activities. Let me piggyback on what Ula presented, the maturity assessment. Last week, we had a team from HISP India to conduct the maturity assessment field work in Laos for the first time. So hopefully we will be releasing the final report in a couple of weeks. Then last year, we supported the Lao government, Ministry of Health, to launch its first digital health strategy. There are 5 strategic pillars and many strategic projects, but I'm not going into details. I will narrow my focus here only to DHIS2 related activities. So based on the strategic pillars, we support the launch of unique health ID that is related to the client health registry that was presented yesterday or day before. So I'm not going into details because most of the activities I described here already presented by our colleagues from the government and from HISP Vietnam. So then other than the client health registry, we support the implementation of org unit profile or health facility master list. And also, WHO is supporting the government to develop a HRH information system that will be linked to, integrated with DHIS2. Then, before last year, before 2023, it was mainly TB, HIV, malaria programs were using tracker programs. But last year, in collaboration with UNICEF, we supported the National Immunization Program to launch electronic immunization registry. Again, that was presented here. So we introduced a module to capture individual children who got immunization and then rolled out last year successfully countrywide. And last year, we captured over 70% of newborns. So based on this success, now most of the programs want to move on to tracker programs from aggregated data collection forms. For example, MCH, piloted in, that is to capture antenatal, family planning, antenatal, delivery, and postnatal care. That was piloted in one province and planning to roll out countrywide. Then we are expanding the electronic immunization registry adding other components, for example, growth monitoring, then early childhood development, and then deworming, sick children, vitamin A, etc. So expansion of EIR. Then we will introduce IPD tracker. That was also presented here to enter IPD discharge summary, including ICD-10 codes. In Laos, we are using ICD-10 yet because we don't have the ICD-11 translation. Then related to that, we will, later this month, we will roll out MCCOD tracker program in provincial and district hospitals. So we support that, and then again, in collaboration with UNICEF, we are having a project on strengthening nutrition information systems. So this is the last year. We have been supporting over the last 4 or 5 years during COVID time to strengthen nutrition information systems in the country. So that is supported by EU. Then this year we received considerable funding from GCF, Green Climate Fund, to strengthen the climate-resistant, climate-resilient information systems. So we did not receive the funds yet. Over next 5 years, we are planning to strengthen the health information system, integrating climate data, and then the disease surveillance data, and then forecasting outbreaks, etc. So again, we are collaborating with DHIS Vietnam and Oslo on this project. And then, as we know, like in other parts, NCD is a major problem in Laos. So we are planning to support introduction of tracker programs for NCD surveillance, cancer registry, and then injury surveillance in near future. I think that is all from the country office. Unfortunately, my colleague from the regional office, HIS coordinator, could not join the conference. Therefore, I will briefly update you about our support from Wipro regional office to the countries in the region, very briefly. So we have, as you know, 37 countries. Out of 37 countries, Laos and then Solomon Islands, Vanuatu, are using DHIS2. Other than that, you heard like new countries are joining, PNG and Cambodia. Also, Kiribati is also exploring using DHIS2. So our regional office is supporting them, all these countries. I think that's all I have. Thank you.
Thank you very much, Achala, for sharing those updates from Laos as well as the Wipro region of WHO. So next, after Laos and Wipro region, we are moving to the WHO Southeast Asia Regional Office. So we have here with us Ruchita Rajbandari, who will be providing us updates. And also I request Ola and Achala to please come forward and take chairs here. So it'll be easy for us to interact when we have the panel discussion.
She has a slide, 0. Can you get it on day 3? Day 3? Yeah, okay, 0. Yeah. Did you see it? It was there, don't worry. Yeah, this one. Updates from 0, yeah, that's all. Half of them are wrong, but doesn't matter. One is looking for school, right? Yeah. Not that one. The Sierra's guides. It should be this one. Yes, I opened that one. Maybe it's at the bottom. Try. Maybe attached to it. Let's go for this. I know it's here. Wait. This is one, yeah? Yeah.
right, yeah. Can you reach here? Right, you can start, you can use this one.
Oh, yeah. I think it might be, should it be better?
Yeah, or is you use?
Yeah, okay. Oh, it's not coming. Sorry for the technical glitch. 10 more seconds, right? This is beyond our control. Are you sure?
Yeah,
I'm not here.
yeah, okay.
All right. Yeah?
Yeah.
It's okay, I don't need it. All right. Sorry about that. Good afternoon, everyone. I'm Ruchita Rajpandari. I'm a technical officer at the Health Information System for WHO Regional Office for Southeast Asia. So talking about WHO CRO, we have 11 member states in our region. Although the number of countries might be very less, we do have 25% of the world population residing in CRO. We have Bangladesh, Bhutan, DPR Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, and Timor-Leste. So I've been asked to explain what, CRO does in HIS, what HIS unit is doing. So basically, we work very closely with our country office and with our member states to strengthen health data system. The health data system that we work falls within the SCORE framework, the WHO SCORE framework, which Ann will explain a little bit more. But the area we work in is the SCORE of the 5 key essential interventions. The S, the survey, the count is CRVS, and O is optimizing routine health data, which we work to improve the data availability and quality. And R and E, which is the review and enable, is we work towards enhancing synthesis, analysis, access, and use of data. So we work across these 5 key interventions so that we can have a strong country health data system that monitors health-related SDGs, UHC, and also build a strong, resilient health system. So, thanks. Okay, so WHO conducted a SCORE assessment round 1 in 2018-2020. And you know, the 11 country, across the 5 key intervention, we can see our 11 country score, which is the right bar. And also we will be conducting SCORE assessment round 2, I think in next month or so. So these results will be updated. And from here, what we can see is the 11 countries have varied degree of maturity within the health information system. Some countries, the maturity might be more towards the SCO, and we can see in our countries the C, the R, and the E, which is the CRVS, the routine health data, and the data use is pretty much lagging. So the kind of support we give to our countries very much depends on the country priority, the country maturity, and the country needs, all within the health information system. For instance, in Bangladesh, we are currently supporting Bangladesh set up terminology registry, while in Indonesia, we're working towards strengthening CRVS. In India, we're supporting with the transition to ICD-11, while in Bhutan, as we've heard, Maldives, Timor-Leste, we are supporting towards the O, which is the improving the routine health data system. So while I'm here, one of the ways we are optimizing routine health system is among the 11 countries in Southeast Asia region, 7 of them use DHIS2. So we leverage on the HISP Asia expertise to provide technical assistance to them. So like I said, just like how the health information system maturity differs among our countries, even the DHIS2 maturity differs. So the countries have different needs, different priorities, and how we have done it with this APW with HISP Asia is we've divided our assistance in 3 different ways. So first would be the core essential DHIS2 HMIS assistance, where we're conducting HMIS maturity assessment, where we're assessing countries' data architecture, flows, and also we are supporting with DHIS2 version upgrades. We're also providing capacity building, because at the end of the day, we do want them to have a capacity at MOH. So again, these capacity building activities are country-driven, country needs. So we are doing server administration, database administration, API integration, a lot of focus on data analytics and use, including dashboard. And we also provide specialized DHIS2 TA. For instance, Bangladesh has requested for an IPD morbidity app. And Timor-Leste last week, for instance, HISP Asia was in Timor-Leste supporting with the establishment school health information system in the national HMIS, known as TLHIS. So these are the kind of varied support we've been giving and we continue to hope to give. And Pamod has specifically asked me to emphasize on our long-term plan. So there's nothing such as long-term plan, but as CRO, what we really hope is we work really closely with countries and our country offices to build strong health data system such that they produce reliable, timely, and quality data. And not only are they producing this data, but they're also using these data for monitoring population trends, health, for monitoring UHC, SDG, and at the end of the day to have a strong, resilient health system. So that's a brief presentation from CRO and what we do and the kind of work we do in the realms of health information system. Now over to Anne for more details.
Yeah. Thank you, Ruchita. You can take a seat up here. Right. So now that we have updates from WHO country office level and Southeast Asia region, let me invite someone who's no stranger to this region, who has worked in countries and supporting region for so many years, now of course in WHO headquarters. So Han, yeah.
Good afternoon, and I apologize for missing so many presentations earlier, but that's also, I might talk a little bit long, just trying to wrap up. So just before I start, one question to the audience. Out of here, how many of you have heard of or implemented the WHO standard routine health information system toolkits? Raise your hand. The routine health information system or the data quality toolkits. Okay, I think that I have the right audience to talk to. So we have I think what I would like to share here is the implementation and what we can learn. In the last 2 years and this morning, we've heard a lot of what is happening in the countries and how DHIS2 has helped in terms of strengthening the health information systems. So I would like to focus on the next one. So we have to talk a lot about data collection. We think by now we understand the needs of collecting data. So before we start, I also ask you to think of what is the use of it for? What is the next step of all this data collection? And I think this is something that we will need to shift the way we think in terms of we need the data, we set up something to collect it. But now we need to say what we want to use the data for and how we're going to get it. So this would be something that I would like to raise. Okay. It's very interesting. Okay. So just quick introductions. I think I've known maybe half of this room. I used to work in Laos for 9 years, setting up the DHIS2 and the health information systems there. But also I've been working a lot with the Western Pacific Regional Office to support several programs in terms of strengthening data use, harmonizing and integrating and sharing data systems. And then I've moved to HQ for the last 6 years and responsible for several areas. And I think I would like here to raise 2 key areas. One is on the routine health information system, and the second is the data quality. And with that, my other responsibility is coordinating and work very closely with the HISP team and the HISP Center on supporting countries that use DHIS as a way of demonstrating the value of having an integrated data systems, how we can make the best out of what we have in terms of resources, and then how we can make the best use of the data that we collect and generate. So this is what the vision we have, and I think we've heard a lot of all the different, and Ola mentioned about how many countries and how many instances of DHIS2 we have. I'm sure you all have more than one instance of DHIS2 in the country. And we also see that another thing is, if we have a very strong and well-structured data system, not the data collection system, the system for data collection, data analysis and use, and how easy it is to make it, to adapt it, and to also bring different innovation into the system, which is the case of Laos, for example. But we have a lot of paper-based. This is where we all started at some point in the last 5, 10, 20 years. We all wanted to go to something extremely fancy that everybody talking now at the moment is the digital health, and how to define that. And I really like a lot of regions in WHO, they have switched from the term of digital health into the digitalization of the health information system. Why is that? It's important because we have to digitalize something. And that something is the system, you know, as in Ola's presentation, you talk about the foundational structure. We need to see what data we want to collect, how we collect them, how many times we have to collect the same data, or how can we reuse the same data we collect, how they connect to each other, what are the products we wanted to develop, to generate every month, every week, every day, every year. And that is the core business of the health information system. Then we can digitalize it with multiple different ways of technology, which also has been presented throughout the last 3 days. So I will start with how we work together with the HISP Center. So University of Oslo HISP Center is WHO collaborating center. And we have a common agreement on how to support country to strengthen the capacity for the data system through capacity building, through operational research. And I think what I like best is how we learn from the country, how different implementations that taught us, so we can make our tool, our standard, our norms and developments in a more easy to use and more practical to the country level. So I got this from the HISP Center slides, and I just say this is the step that we do in terms of translating what has been done by WHO, which is in the frame, and then how it is going to move into the DHIS implementation, and that's why I ask about the toolkit. So for the toolkits, this is an ongoing work, and it has increased. When I took over this task, we had 6 programs: TB, HIV, malaria, immunization, and MCH. And now at the moment, I'm coordinating with about 15 different programs in WHO alone to define the standard. And one of the biggest challenges is how to get all these different programs to share the data, to talk to each other, and to understand that at the end of the day, in the country, we have a common products. And this is what we would like to learn from the implementation from you, so that we can bring it back to us and then use it as evidence to, by the way, to best design the data system and the standards. And one of the key cross-cutting that is about the systems, which is about master facility list, was about the unique ID, that's about the data quality, the coordination, and the data governance. So all of that key principle is the foundation or the umbrella of the health information system. And then we have the HMIS, or the facility-based, the management products, that is the core business, the bread and butter of the HIS. How we bring all the data together and have aggregated data and the dashboard that support the management of the facility and management of the programs. And then we have a program specific that look for You know, we all know about the TB, HIV, malaria, immunizations, and that is where the demand increases, but also where the design of the system varies, and how we're going to bring all of that together and make the system work for the country. I understand that this is my biggest regret for missing the first day, which is the mortality, the ICD, and the data quality discussion. So we have worked together with HISP to develop this app in the DHIS that translates two things. One is the medical certification for cause of death from the WHO standard into the DHIS2 data collection form. And secondly is to have the interoperability, the data, the embedded link with the ICD-11 back end in WHO to DHIS so that country can use it. This has two significant impacts. One is to make the very complex and sometimes very varied data collection and for cause of death in the country, make it standardized and follow a certain workflow, and also help whoever desires to understand what is happening in the country. And by doing that, trying to improve the collection of cause of death. And I think cause of death after COVID has become one of the key interests of not just a lot of government, but also a partner as well, because when we did one of the key products, the excess mortality due to COVID, there are more than 70 countries couldn't report data on death. And without knowing the mortality, we will not know much of the burden of disease we have in the country. Second significant is that we started the linkage between ICD-11 and how we can link that with owner morbidity. So this has been another ask, and there will be another big step of development that we are also trying to work together with University of Oslo and other partners to see how we can bring it into the system. And then the next one is the last mile logistics that Breno presented this morning, because that brings a lot into the management of the health facility. And that's also one of the biggest gaps that show in immunizations, and now in a lot of programs specifically on the non-communicable disease when we need to monitor the drugs and the testing for hypertension and diabetics. This is one of the products I don't think we need to show, but I'm sure everybody talked about this already. So what we have learned so far in the implementation. Last year we had this workshop that I invited 6 regions, and we discussed a lot about how to implement and make the implementation of DHIS2 for the WHO routine health information standards more effective and efficient. Why? We know that it's very easy to scale. The background here is a map that within the last 6 years, we have increased the number of countries implement DHIS2 for the routine facility-based data systems from 25 countries to now it's 90 countries. That is the impact of what we do. That is the impact of how we can work if we have a common standards, if we have a common approach, and you have a systems that enable us to make the implementation easier, let alone that it's also way more cost effective than buying different software and maintaining it. It's very easy to configure, but that's why it's also very easy to go silo. You can easily have a one DHIS2 instance for TB, one for immunization, one for nutrition. But then the key thing is, then is it really effective? Or how are we going to work that together? And then we also look at depends on how you look at it. I see the positive side of it is that when we look at this, it's a very good opportunity for the Ministry of Health to be the leader of health in the country, bring all different programs together and say, look, this is what we need to have, and this is the role of Ministry of Health, to coordinate, to identify the needs, and to see how we can make more out of the less in data that we collect so that we reduce the burdens of data collection. We just had a case studies that we look at 6 different countries, and the conclusion is that 33% of the time the health facility spend is on collecting data. But do they see the data product? No. Do they use them? Very little. So we need to change that approach as well, to see how those who are spent 33% of the time should be less than 33%, but they should be the first to see the data and the first to use it. Another experience we also learn is that the linking between different systems, I think we have talked a lot about today. We have LMIS, we have a lab, we have a CRVS, we have WASH, we have education. How do we go into all of that together, and what is the use of that for? So it's a challenge, but at the same time, it's also the bonus. Because if we are from the government perspective, this is where we can show our roles as a leader and ownership of our data system. The challenge, capacity, change of staff all over places, the turnover, when is training is enough. So we need to see how we're going to change the way we do the training as well to make it more effective. That is the technical side. And then let alone, I also learned that when we introduce the standard metadata, the biggest push we have is that we have a very small list of core indicators that normally country will have to report to WHO anyway for the program annual reports. Now, but when you go to the country, every country have your own data system and different definition for each of the indicator. How are we going to harmonize that and standardize that? So again, it's easy because it's adaptable, but how far is the adaptation can go? How far does it link to the quality of the data? So these are the key areas that we need to consider. And we also see how we're going to design it. I think one of the very advantage of the DHIS system is to have a data elements. That means we can have a different indicator built on the same set of different data elements. So if we standardize these data elements, we can have the indicators that help us. So we also have to find a way to see how we can best design the system so that you do not need to have so many data elements to collect, but reuse them as much as possible. I think the biggest challenge for implementing DHIS, if we really want to have an integrated system, is the non-technical parts, the data governance to build a foundation. So how are we going to collect on the master facility list? How are we going to update them? How are we going to bring other sectors, especially private sector? I think Nepal, Bhutan, many of the countries in the Middle East region, you have nearly half of the facility of private sector. How are we going to bring it in? And that is not health alone. That is a data governance, that is a legislation, that is coordination. So please, the Ministry of Health here is the key stakeholders in this, and that is your role as a leadership as well, to make sure that you have a roadmap, you have a strategy, you have a overarching work plan for health information system that you bring on the different sector and the partner in, because I haven't mentioned, but one of the key challenges is to get the denominator agreed, the age group agree. In HQ, we have massive problem of agree on the age group because of the needs of different programs. But a lot of it can help with the data design system, but so a lot of it is to see how we can change our mind as well, shift it into something that is more practical. So that, I think, going back very close to what Ulas and other colleagues said about the long term. You go long, we need to go together, and we need to see what has been the plan for 1 year, but also to see what we want to achieve in 10 years' time. So by doing that, we have a last product here, which is a strategy for strengthening routine health information system in the country. And one of the key change of this is that we do not talk about data collection. We talk about data use and put the data use as the center of whatever you do in the data systems. So if you are sitting at the Ministry of Health in the planning department, that is the HMIS. If you are the director of any health facility, that is a health management, health service management. What data do you need? How do you need them? And what do we have and what we do not need? I think that is a key point. And then from there, we can design something that build for short-term, medium-term, and longer-term goal. We have a longer term, and we all share that, which is the SDGs, the USC. But break it down into different ways of monitoring that, and you will see there's a lot of items of that can be done and can be monitored on a more routine basis. And I think also back onto that with what Ulla said earlier, is how we're going to do this. It's bringing the partner in the country to support the strategy implementation. So instead of having multiple projects, we have one big project, which is the National Health Information System Strategy or Digital Health Strategy, that all the partners should support that plan. Where we know where our supports are, we will be able to enable it and bring it in as a common goal and common target. My last slide is about the score. I'm just saying it, Ruchita has mentioned about what score is. This is, to me, the first three letters is about data collection systems. So we have surveys, we have surveillance, we have census that cover all different parts of impact monitoring and the denominator. We have the CRBS, the denominators, but also understand our populations and the target populations. The O, which is the routine, the facility-based data systems. And I say systems because nowadays we are not talking about one. We're talking about multiple systems. But these systems need to talk to each other. And not to merge everything, but to be able to identify the doors that need to be opened for the data to be shared and to be used. The last two, that is the non-technical part. And the R is the review, the use of the data. And this is not just the health sector, the statistic office as well, and other sector. And the enabling, which is the non-technical part, the data governance, the logistics, the data system, the human resource, the investment, all of that is in there. And I also said because we are launching the second round of assessment of score this month. We have changed the way the data is collected to the last round. So this round, the Ministry of Health leads the data, the completion of the survey. And you will hear from the WHO country office soon this month on access to the data and how we can do that together. And I think Pakistan is one of the testing country, Sri Lanka is, Laos is. So we learn from that, and this is a time when the Ministry of Health can exercise your role as a leader and coordinate and get the assessment done. And we're also trying to not just look at your current status, but also to see how far we have progressed from the first round. And I think COVID has made a massive impact on the data system. And in a way, it is a positive impact because it drives the needs of the data. So with that, I think I should stop because I talk too much.
Please. Thank you so much, Han. Now that we have received updates from WHO at country level, regional and global, let's hear from another partner who's very active in the domains of RMNCH, immunization and many more. So let me invite Shukrat from UNICEF Country Office, Lao PDR, to share some updates.
Good afternoon, colleagues. As you can see, we are not big in numbers. So probably I will reflect, I will start with Lao and then a little bit talk about our regional initiative. In Lao PDR, UNICEF involvement and support the government of Laos for the past 5-6 years was limited to elements of digital health, like the development of an IMCI app that would help health workers to estimate diagnose, estimate, and then so the app can lead them, help with treatment and management of IMCI cases. It is both in English and Lao, and it has been we have covered the whole country, and slowly we move to the e-learning, especially not thanks to COVID, but because of COVID. We have developed e-learning tool for vaccine logistics and cold chain management, which also shows its effectiveness. But the real UNICEF involvement in Lao PDR, and also I would say in the region, was with a regional initiative called Improving Immunization System, when we received a $10 million grant for 10 countries, and particularly for Laos, we received 1.7 million US dollars. And this was a strong impetus to start implementation of electronic immunization registry in Lao PDR. So the idea of electronic immunization registry was since 2019, but due to many reasons, and also assessment of 2019, it was stagnant, and there was no kind of passion to implement EER when especially the assessment says Lao is not ready. Then COVID comes, and COVID makes things work. And based on COVID experience, jointly with WHO and the government, we felt let's use DHIS2 electronic immunization tracker, which have been presented. I don't need to talk about that. Interestingly, is different countries use different tools, and the concept of this regional initiative was use technology for development innovative. So it was so difficult for, I'm sharing with you the experience, and I think many of you have gone through the same path of selection. When there is a donor suggestion, they said, bring something innovative that can solve the problem. On the other hand, you have a routine stuff, which is like DHIS2, which is not now for 30 years now. So we had to strike a balance between that and DHIS2. So we opted for DHIS2 ER tracker. We are facing, of course, numerous problems. I wouldn't say that this is a perfect solution, but it is a solution currently for Lao PDR. We are seeing that nesting this digital, ER in the digital health under health information system, the data collection, data reporting is working perfectly fine right now for the past 6 months. Since January, we are covering all children, but the issue is data use, data analysis, data application for planning and correction purpose. This is grossly missing. And one of our worry is that if we are going to continue simply focusing on data collection and reporting without due attention to application to the programming, the purpose of a tracker as such, what we are going to track and how we are going to use this will be compromised. So these challenges, making UNICEF to find solutions, and UNICEF is always looking for rapid response, so we need to strike a balance between taking a time to think how we are going to do, when we are going to do, and also rapidly responding to the emerging need in Lao PDR. So our provision of mobile device management, we procured all Android tablets to whole country, so more than 1,100. And we linked all of them with the MDM, mobile device management. We can see now who's using, who's not using, and for what purpose, and then it doesn't allow to others to install or download other apps other than, you know, so it is also helping for the first time to unify all the use of tablets, and then we can see what type of equipment was lost, what is battery life, things like that. So it is also a big learning for us, for UNICEF. As I said, WHO Lao country office has been lead and always a lead. So we are complementing each other. UNICEF bringing $1.7 million and then a huge implementation field experience mechanism. We recruited about 40 consultants to do this exercise, and that's why we have achieved significant results. Now it is time for us focus on the data utilization and improving the program, including vaccine logistic, including cold chain logistics, which are still an issue in the country. Like M supply has not been, couldn't answer improvement of the national immunization program needs for the past 5 years. So these are the challenges, and you know, we probably I'm talking about more challenges and more plans because our colleagues has already reported what they have done it. We have our funding till the mid next year. Some significant funding, and we are really looking for cooperation from HISP in general and HISP Vietnam, and also looking for WHO stronger collaboration in addressing those challenges, and dividing and roles and responsibilities on this health management information system is required. So we can see from the presentation of a previous speaker who also worked in WHO, the materials, the areas presented by them is huge. So UNICEF cannot be involved in all this area. We are mainly targeting certain areas, and then we have funding for that. And when we implement that, we need also moral, technical, shoulders and support from our sister agencies and also technical agencies. Thank you.
Thank you very much. You may come to the panel. Shukran. Yep. Please. Right. So the final partner that will be presenting to us today is from World Bank. So let me invite JP Acuna from World Bank to share updates from World Bank. So while the presentation is being prepared, I request colleagues in the audience, so please prepare with some questions that you have for all the partners. So we will try to have a Q&A session for at least 10 to 15 minutes. So please be prepared with some questions so we can move on to the Q&A sessions once JP has presented. Over to you.
Thank you. Allow me a few minutes of your time to provide some updates from the World Bank side. So I'm JP Acuna. I'm a senior digital health specialist based in Metro Manila in the Philippines, but I do support other countries as well in the Asia and Pacific region. Before I go to my updates, quick introduction on my end. I started with the bank in this position just this April. But before that, I was a consultant of the bank for several projects. So health is one, welfare, poverty, agriculture, and education. So it's pretty much all over the place. And I really see a lot of synergies with other sectors as well with what we're trying to do with the health sector. So I'd like to share with you this important update. So last year, we had a publication called Digital in Health, Unlocking the Value for Everyone. So this was a collaboration of multiple country offices in the World Bank, and also contributions from partner development partners as well, like WHO, UNICEF, and other UN agencies. So this is actually a compilation of global macro perspective analysis and synthesis on what's going on in the larger digital health space. So you can actually take a look at this publication, and you'll find it very useful, whether you're implementing at local level or at the national level, because it provides you a synthesis of different things you need to consider. Probably some of the issues and concerns are already happening in your respective countries, but this publication provides you some insights on potentially how you can address those issues moving forward. It also gives us some insights on how the data right now is being used or can be potentially used for AI applications. We have a lot of global practice a team engaged in the analysis of where it can be headed, and also what are the considerations ethically, programmatically, as well as on the fair use of the data that you have for AI. So I encourage you to take a look at this publication. As a practitioner, definitely you'll get some insights here. It will broaden up your perspective on how you implement digital health solutions at scale. Another significant update from the bank is just recently our president announced to create a digital vice presidency for digital transformation. This is quite significant for the bank as an organization because we have representative at senior executive level about digital transformation. So this is not only covering for health, but this also covers for the larger digital agenda that the bank will be supporting. So please watch out for further developments from the World Bank. We're increasing our footprint in the digital space. So you'll get to see digital health at the forefront with digital solutions in education, in welfare, in the energy sector. So all of those are supported at the foundation using digital tools and technologies. So expect a lot of developments from the organization. For my last slide, I just want to highlight that I have seen significant presence of the bank through projects that I'm personally involved in. But I also see a lot of future ways forward for other countries that are still in the infancy with working with the World Bank. So majority of our engagements are really on financing and lending operations. So as you know, we have World Bank projects in various countries. And it's driven by country loans. But within those lending operations, we find significant value of the bank, especially for those health information systems that need scaling up. We know for a fact that development partners are instrumental in introducing digital technologies, but sometimes when you talk about sustainability or scaling up, that's usually where the bottleneck is. So oftentimes, that's where the bank comes in, and we can have a conversation on that. And we can co-develop your scale-up and scale-out design for your health information systems. So we really see a lot of value from the bank side on the service delivery side. We have seen several projects looking at local health system strengthening, wherein there might be national government information systems that are challenged when you get to roll it out to facility level implementation. So we do have projects that focus on those. And also promoting governance as well, especially in the case of our multi-sectoral nutrition projects. I know for a fact Laos has one. In the Philippines, we also have one. So these are projects that are involving multiple government agencies. And data sharing is one major challenge there. And also, how do you maintain a project that is being driven by different ministries? So I think that's also where the bank can come in, because we can drive a conversation at the policy level on these kinds of projects. Majority of the activities I'm heavily involved in are called advisory and technical assistance services. So while we do have lending operations, we do also have a technical advisory role to fulfill for our country ministry counterparts. So every now and then, I get pulled into a country and then helping them come up with proof of concepts, minimum viable product developments, and explore with the ministry if that is worth pursuing for larger funding and financing project. And also, we bring to the country and the ministries access to global knowledge and experiences. So, for example, we have country engagements in the Pacific. They ask us, can the World Bank help us benchmark on this kind of health information systems? Then if we do have presence in the region, and then we can bring up our reports, our knowledge products into the table and help the country make a decision on their ways forward for their respective investments. So I'll be happy to discuss if you have any questions for the bank. Thank you.
Thank you very much, JP. Yeah. All right, so now we are done with the presentations. It's time for a round of Q&A. So do we have any questions from the audience? Okay, maybe I can start. So as implementers, one challenge that we see engaging with I think, CRO is, maybe Ruchita, like I think she's in the middle of something, so she will join, Right, so one challenge that we have as implementers in the country is aligning with different donors for coordinated efforts. So when we implement projects, how we can collaborate with different donors, partners in moving towards a common goal. So this is actually twofold. So we see this challenge at country level and also sometimes meeting the priorities and interest at regional and a country level. So can you all share us some examples of where you have seen some success in achieving these challenges, or any plans, any immediate plans you have, and some recommendations that you have to collaborate amongst donors? So who wants to start? Maybe WHO or?
I'll first put my country hat on, and then I can go to later on. So when I was in Laos, and I think one of the early success in Laos was two things. One was the decision by the Minister of Health to have the one gate for all the data that is going to be published. So it is the HMAS Laos, and that is so all the programs, if you want to be published on the annual health statistic reports, if you want to release your data, that data have to come from the same systems. So that is a decision from the minister. The second is that we have a one HIS plan, strategic plan, that all the partners in the country endorse it and agree to support that. And then the vehicle to help that implementation was a set up with a partner coordination meeting. So there was a quarterly meeting that led by WHO at the time that bring all the partners together, and we have a one session on the health information system. And the Ministry of Health also have a biannual meeting, so twice a year, the minister or vice minister will chair that meeting with all the provinces and the partner together to go through the progress report, but use the same platform. And with that is one of the best things, because then you have something that everybody can relate to, and that also something that they wanted to be seen in that platform. So that was my biggest lesson I learned in terms of the non-technical work. At the global level, we have the Health Data Collaborative. We're also trying to work on that modules. And the DHIS2 team, together with World Bank, Global Fund, USAID, and other programs, they are part of this working group as well on routine health information system, where we're trying to find a way to support countries. And one of the big pledge is please support the country the way that we do that in a coordinated way. So the latest example I had was DHIS2, which is USAID funded projects. And they are the one who launch and disseminate the WHO global strategy. And I would ask all the partners to do the same. The resources are scarce, so it's better to put it together than doing a separate way.
Yes. Maybe let me add something to what Anne said. Like, as I mentioned during my presentation, we have the first digital health strategy in Laos, and under the digital health strategy, we have 37 projects identified, and that is mapped with different partners and donors. And we continue the same quarterly meeting now as a technical working group led by the Ministry of Health. So every quarter we look at the progress of the implementation of digital health strategy, that is basically the 37 projects. And we sometimes we understand there are certain projects, there are many partners willing to support, but there are certain projects no one is willing to provide funding. So those are the issues we need to improve the coordination. And then again, as I said, we recently conducted the maturity assessment, and based on the recommendations, we are planning to disseminate the recommendations among the partners and donors.
Right. Thank you. Yes, please, JP.
Okay. Yeah, I can give you one example of the problem in the coordination. It is related to CRVS, birth registration. So in Lao context, we have World Bank, which is supporting Ministry of Home Affairs, and they have their own app, funding, provinces selected, and they're implementing, moving forward. And on the other hand, you have a UNFPA chair on CRVS, WHO technical support, and UNICEF child protection team talking about the necessity, importance, and then doing good advocacy. So there is, because of this lack of both technical coordination or whatever, it is not because unwillingness, but because of whatever design, we can see that this CRVS is still limping. So it is not going the way it should be. We have brought this issue to the different level, and we would like this cooperation of UN agencies and World Bank, that we could bring a solution, because we have some technical suggestion. So these are the things making us to think that we are missing here strong government leadership. And I can give you the other example from Bangladesh, where CRVS was discussed at the Cabinet of Ministries. Deputy Prime Minister was leading CRVS, and the partner which would sit in a steering committee were the ministers of different ministries. And then director of HMIS was a kind of a technical support to lead and to discuss. So I could see how, at least at the coordination level, things was working quite well. I think we need this type of, at some point, we need a strong government leadership and willingness to coordinate, which will help to reach efficacy and funding efficiency utilization, and moving the program faster than it's required. And then in Lao context, are we going to consider health centers, like for example in Tanzania, we have done it, where childbirth, primary healthcare center was considered as a birth certification, birth notification place. Then, for certification, it goes to the village. So with that solution and recognition, the health center as a point for birth and death notification, a lot of things have been resolved, and it jumped from 10% to almost 95% birth registration. So the kind of a small agreement, small decision based on the common consensus, and that requires a good coordination. Again, I'm bringing more challenges here, So which is especially World Bank.
Yeah, maybe a quick update and then we'll take the next question.
Yeah, just a quick addition to what I've been said before. We also work with existing governance mechanisms with the countries that we're engaged in. But most of the time, the bank gets pulled into the conversation with a request, either coming from the Ministry of Health or with a request coming from the Ministry of Finance or the Economic Affairs. And oftentimes, that's where we also get a sense of how we can complement existing projects or initiatives already in country. And then when there's usually funding gap, that's where we come in. But before we mobilize large resources, we often do some small technical assistance to really get a sense of what's needed, like some diagnostics, some analysis, requirements gathering, and then we report that back to the government. So I really highlight how important government leadership is at that stage, because how projects at scale will be implemented will be really dependent on the capacity of government to take it on.
Thank you very much. I think we have a couple of questions from the audience. First, we can take the question from PNGS.
I'd just like to make a comment here. Thank you for the partners who are really supporting us in health information. One thing that I see is that the partners do have their own interests as well. And that comes in to really disturb the actual plan for the country. And so in terms of implementation, it tends to not achieve the goal of the government. For me, I think looking at coming to this conference have really taught me some lesson in terms of getting university involved. And that is to get them to really understand how the system has been working in different countries. And I think I really want to support that way going forward in terms of getting the university involved for research purpose. And so that will have a direction in terms of going forward to improve the systems in different countries. So for me, I really support this, this conference, and I propose that we have IPS in PNG to help us to have our system strengthened so that we can see how we can achieve our goals. Thank you.
Thank you. Hanan?
I actually go back to the law things again, because what Shukrat just said that there is a problem of coordination. But Achala said there is a health policy already there, so already legislation and framework is there. So how then can happen? One. So we need definitely a good leadership to guide this, so that the donor cannot do on their own. But for Shukrat's experience on the birth registration, birth notification, yes, that's definitely a good idea. In Bangladesh, we're doing that thing. So we are actually notifying birth from the facility immediately after the delivery is done. But also we propose in the CRVS technical committee that all health facility should identify it as a register himself. So this last year in coordination meeting, I proposed that. So this year, this is proposed, this is going to the Prime Minister's office for approval. So if it's approved, then all hospital will the authority to issue the certificate. Then a big problem will be solved. I think other country can follow this as well.
Right, thank you. I think it's a comment, so maybe, yeah.
Thanks a lot for all of this useful presentation and sharing experience. Actually, I have a comment, as there was in the first presentation point regarding sharing information and maturity assessments with different donors to get the needed benefit. As implementing partner, we try to reach and access some maturity assessment from different parts of the regions, and we did not get the access. So would it be possible for the University of Oslo to facilitate that and facilitate sharing the knowledge and maturity assessment with all partners?
Yes, Ula can answer that.
Yeah, thank you. I think first of all, the maturity assessment should be owned by the government. So I think we really recommend that you go directly to the government, the HIS unit, whoever did the assessment, and ask for access. I think my encouragement was really to get the countries here, the governments, to share and update their plans with the partners. We support the assessment process, but it's led and owned by the government itself. So I recommend you go directly to them. But we can help put you in touch with the right people, perhaps. Yeah.
Thank you. You have a
Yeah, just to respond to the comment from colleague from PNG, and I fully agree. And I think this is exactly the point when I say just put the needs of the data, not the collection, the use of the data. What data do we need for what purposes? How often? Who use them? And that we are doing here. We support country, so we should put the country needs first. But then at the same time, to make it easier, that's why all the standardization is there for, so we do not have to start from scratch. And I think the building the capacity in the country is very crucial, because there is always emerging needs, there's always different requests. So how are we going to meet those and respond to that with what we have is a key thing. And I think if we are very clear of a design of what we want, and then the role of the government, and we are all committed to support and empower the government in the ministry to coordinate and lead that. And I think all the donors here have a project, yes, but the project is not, it's for the country. So how are we going to bring that and facilitate that so that it's a win-win situation would be, I know it's not easy, but it's doable.
Right, thank you. Any more questions? Okay, until we get the next question from the audience, we have a question from the HISP Asia Hub. So listening to all these country presentations and what we have seen over the years, we realize that we need capacity building, which we have to continue. And while we are conducting so many activities in the country and so many different capacity building training activities online, it is very crucial for us to have these kind of regional events. For example, it could be the HISP Asia conference, or else the regional academies that we are continuing. But a main challenge that we have is like how to get the resources for the countries, the ministries to attend, and all the trainers, facilitators to organize that. So do all the partners realize these kind of regional capacity building activities as important? If so, do you have any plans in supporting these regional activities in this Asia region?
Yeah, at least for the projects I'm involved in the region, it's also the same question I have. How can we understand exactly the need from different country offices, country ministries rather, on this space? So for example, we received a request from a country, and then we're going to mobilize something, and then here's another request from another country asking for the same thing. We know for a fact there's economies of scale, right? So if we can probably pool some funds somewhere, it might be like co-financed by another development partner, and then the bank will be supporting those that are part of ongoing bank operations. So I think I have seen that model happen in other countries, so it can be done. And we're really looking forward to having a conversation on how to joint finance supporting activities like these, at least for the countries we're involved in.
Thank you. Yes, Achala?
Thank you. Let me add something. Actually, we support not only activities like this, but we strongly believe to develop build the capacity, we need to integrate digital health into the curriculum of the health courses, the degrees like doctors, nurses, and etc. So, like what we did in Sri Lanka, sometimes back with the support from Oslo University and NORAD, introducing health informatics masters and doctorate program. And now I think we have produced more than 150 experts. And last year, I think we started in Nepal. 2 universities introduced master's program. So similarly, in Timor-Leste, in the digital health strategy, one pillar is workforce. So under that, we propose promote the integration of digital health into the curriculum of the health programs. But again, WHO is not funding organization. We promote this idea, and we invite the donors and other partners to support this.
Okay. Yeah. All right. So if there are, yeah, maybe just the final question. Yeah, we can take one more question, and then we'll have to conclude. Thank you.
Thank you. Pius from PNG. From my observation, I see that the partners are usually interested in systems only. And there is little investment in infrastructure. Now, if there is no infrastructure, then the systems are most likely to fail. That we all know very well. In our recent digital health strategy, digital health maturity assessment, we have limited infrastructure. And we are trying to transition a system that's been, a third party has been managing. And that is becoming very, very difficult because the department does not have the infrastructure. So it is a big issue that we are facing. We cannot host the system outside the country because it is recently there's regulation that systems must be hosted in the country, data must be in the country. So that is the challenge that we are facing. So I don't know where we can get support from to develop infrastructure for digital health systems. The country, yes, if there is support from the government, then we can absolutely improve our infrastructure. But there are some countries where that is not really at a higher agenda of the country. So that is just a comment that I'm trying to make within the room. Thank you.
Thank you very much. So any reactions for that comment? Yes, please. JP.
Yeah, allow me, Pius, to respond from the experience of the Philippines. We're actually preparing a project specifically to address that concern. So the Ministry of Health there was really challenged as well on infrastructure, but they realized it's a larger conversation involving another ministry. Usually it's the Ministry of ICT. So we also have a separate team, the digital development team at the bank, taking care of their side on infrastructure. But at least on the health side, digital health space, we were able to include in the design of that project a transitory infrastructure until such time that the permanent infrastructure goes online. So what I mean by that is we're exploring service-based infrastructure to allow the health information systems to work. For example, satellite-based internet, terrestrial-based radio frequency internet. So if those services are available in far-flung areas, in geographically isolated areas, then we're going to take on that service until the Ministry of ICT was able to lay out all the fiber backbone needed by that certain village. So we were able to incorporate that in the design, and the Ministry of Economic Affairs was able to sign off on that concept. So I think my point here is it's a larger conversation. From our experience, it's not only at the Ministry of Health, but you have to involve as well the other ministries in the conversation.
Just to continue what my colleagues from World Bank said, like here we are having, like that my WHO colleague said, we can recommend, we can propose standards and guidelines, globally proven, evidence-based, but we are not funding agency. And then here we have someone who can provide significant funding. So, and then UNICEF has implementation mechanism and control check and balance mechanism, how to implement that, and then bring it to the advocacy level jointly with other agencies and World Asian Development Bank. I think it is also like in UNICEF, we are not talking about health. We are involved in education. We do WASH. We do on nutrition. We work with different sectors and child protection, justice. So we understand this, and when we talk about the child-centered approach, we are talking about a family-centered approach in fact. So it is of significant importance of the government leadership to coordinate all these processes, to bring all the stakeholders around together, and then like Mr. Hanan mentioned, you have in Lao policy, health information strategy and policy. You can have a law, many, but it's all about execution of these policies and strategies. So that is, I think it is not yet strong enough in many countries that we need to also advocate for.
All right. Thank you so much. So with this, we will have to conclude this session. A big round of applause for all the partners on stage as well as in the audience. Thank you. So next, we move on to the final session, which is the closing remarks. So, yeah.
Okay, everyone, so what we're going to do, instead of having the tea break now, we're just going to go through some of the conclusions of the conference. That way you can get out of here a bit early, okay? So if you want to explore the city or do whatever you want to do. Okay, so what we're going to do, we have a bit of feedback that we'd like to collect from you. And I just have a little bit of information for you in terms of next steps, if you want to keep in touch with the community and how you move forward with that. And then I'll ask Saurabh to give our closing remarks. Okay, so please, if you can join this, here, I'll make it larger. If you can join this Mentimeter. Oh. Okay, and it's self-paced, okay, which means that as soon as you enter, you can start answering the questions and move through it. So what I'm going to do, I'm going to leave this up on screen for a couple minutes, then I'll start going through some of the responses that have been entered, okay? And we really do appreciate this feedback. We had a very close look at this last year. We tried to adjust some things for this year, but of course we know there's more room for improvement, and we're happy to receive that feedback from you all. Okay, so like I said, you can start answering the questions once you join, but I'll leave this up on here just in case people are still joining the Mentimeter, okay? And for those of you online joining us, you feel free to fill this out as well. Okay, if you are having any trouble joining or anything like that, just let us know. One of us will come by and help you out. But I think most people, I can see you're filling in the responses on your phones. Okay, let's see. Okay, so I'm going to start going through a couple of the questions that we've received feedback for. Okay, so the conference met my expectations, so we have some good responses here. And for those of you who kind of put somewhat, we'll be very interested to hear your feedback in terms of how we can improve in some of the later questions. Okay. I was satisfied with the organization of the conference, so registration, assistance in hotel booking, etc. Okay, and some good feedback here as well. Okay. This is Hung's question. Okay. I was satisfied with the conference venue, okay, so the location, the facilities, etc. Very similar feedback, I think, to the last question. Somewhat, so some people have some issues with the location. Okay. I was satisfied with the quality of the content within the conference. Okay, so we still have a couple people, I think, who have some constructive criticism for us, hopefully. Okay. The facilitators were able to assist me in answering my additional questions. Okay. So someone disagreed, no problem. Okay. We had a few that agreed and strongly agreed, so if there's something we can do better there, in terms of maybe having some dedicated time for this, maybe that's something we can look at. We'll be interested to hear when we get to the comments later on. I was satisfied with the time and pace of the conference. So this feedback is a little more kind of all over the place. Okay, we understand there's a lot of reasons for this. Okay. If you do have suggestions in terms of how this can be improved, once again, we're happy to hear that. I achieved my goals in attending this conference. Okay, so quite a few agree, one disagreed, okay? So maybe we could find out how we could move more people over to the pink box. I would like to attend the conference again next year. Okay, a lot of people, most of you said yes. So no outright no's, that's good to see. I would recommend this conference to my colleagues and peers. So one person did say no. That's okay. What was your favorite session within the conference? Okay, so a lot of votes for integration and data quality, country experiences. Okay, and the responses for this one are still coming in, I see, so I'll just leave this one up for a second and let everyone to review as well. It might be hard to see, I guess, on here, but I apologize for that. Let me make it any bigger. Okay, so a lot of varied responses here. Looks like people enjoyed a mixture of the sessions. What topics would you like to see more of at the next conference? Okay. So some of them are topics we had. It looks like you'd like to expand on them further. I saw LMIS, for example, interoperability, right? So maybe integration, right? So maybe that's something we can expand on, for example. Okay, more country presentations, more use cases, data quality, modeling, yeah, One Health. Okay, so please continue to enter this feedback where we're collecting all of it still. I feel the following improvements would improve my conference experience. Okay, better mix of countries, better food. Hands-on training, yeah, this is always something we struggle a little bit to balance, to be honest with everyone, right? How much of that should we have versus information sharing? More parallel sessions. EIR tracker. Okay. Sharing of all the videos and recordings. Yes, so all the videos are actually accessible immediately on YouTube at the end of the day. Okay? So maybe I can just quickly share that again with everyone so they know where to access that. All the presentations are also uploaded for you to access immediately. So all the presentations from the last 3 days, you should already have access to. and you should be able to access those, okay? If there are any questions on that, please just let me know, and I'll try to help you out a bit, okay? But the YouTube recordings are available immediately. For example, at the end of today, the third day will be up and running within 5 minutes, okay? Yeah, I see practical. Yeah, so like I said, this is a bit more, more relaxed sessions instead of too many presentations, so giving enough time for each topic. Okay, so this is the last question for the feedback. I'm going to leave it open. You can continue to add responses. I see that we're getting in more responses still for some of the questions. Okay, we will have a good look at this, and we will reflect upon what we're doing for the next year, as well as other types of events that are within the region, not just for this conference, but other types of trainings or even local trainings, etc., where this can impact that, the effect of how those are held. So please continue to fill this in. I'll leave this up. Okay. The other thing I just wanted to do real quickly, for those of you who aren't aware or haven't joined our community of practice, I'm just going to leave this up. You can scan this QR code, and it'll take you through the process really quickly of joining the community of practice. If you haven't already, you'll get the Academy Participant Badge by doing so as well on your name. And you can reply to the post that I made initially on this conference if you would like, and post either positive or your choice of feedback to that post if you'd like to do so. And if you are part of the community of practice as well, of course, we're happy to have you. So we have a very active community manager. So for those of you who are kind of wondering, well, what happens next if you have questions or if you have outstanding issues that haven't yet been resolved, please join the community here. Please post on here. Our community manager will make sure, trust me, he reminds us many times a day that we have to respond to various queries that are on the community of practice in order to kind of help you guys out as much as we can. Okay? So I'm going to leave this up, and I'm going to ask Saurabh to come and give our concluding remarks.
Okay, thank you, Shurajit. So as we come to a close to this year's conference, I would like to extend my gratitude to everyone who has been involved in the making this event a success. First of all, special thanks to the organizers and hosts, HIS Vietnam, and amazing effort from Hong to ensure we all get here. Thank you for the excellent hospitality and seamless organization of the event. So I'll request all participants to give a big hand to Hong and HIS Vietnam team. To our partners, we thank you for the technical support and the guidance that you provide the HIS network, and your support has enabled us to build sustainable information systems. Thank you to the HIS Center for your presence, guidance, and technical support to the entire HIS network. Your support means a lot to us. Lastly, the engagement from the participants helped us, and it was very encouraging to continue the momentum that we've set up in building information systems for the countries we work in. And we hope that we'll get the same support from all the partners and participants and the ministries to serve you better moving forward. Thank you once again, and we look forward to meeting you to the next conference next year. Thank you so much.
So on behalf of HISP Vietnam, I would like to say thank you once again for coming over from all the corners of the world coming here. So I also have read all the comments on the thing. First of all, I would like to say very sorry for that not all the requirement for the food can match diversity. And we do hope that from next time we can improve on the quality of the food, especially for halal food. For now, we still have a tea break outside, so it's the last chance for you to catch up with each other before we leave the conference. So thanks again, and see you soon next time.